Yeah, good evening. It's taking time to load. Just give me a minute. I'll just start the class. So today we'll be talking about conjunctivitis. Okay. So is the screen seen? Is it visible? Yeah. So today we will talk about conjunctivitis. So basically, yeah, it's full screen now. It's full screen. Okay. So first thing we should know how do we differentiate if it is a bacterial conjunctivitis or a viral conjunctivitis. Okay. So remember, both bacterial and viral conjunctivitis are highly contagious. They can spread through droplet infection, dirty hands, okay, through towels, handkerchiefs. Okay. So both are highly contagious. The characteristic feature of a viral conjunctivitis is the presence of lymphadenopathy. The patient typically will have a preauricular or a submandibular lymphadenopathy, and it associated with a watery discharge. Viral usually starts unilateral and then spreads bilaterally. More common in older children, while bacterial is more common in young children. Viral is typically associated with a pharyngitis. Typically, if it is a adenoviral infection, we know about the pharyngoconjunctival fever. Okay, so adenovirus. So it is the pharyngoconjunctival fever in adenoviral infection. So typically, watery discharge via viral conjunctivitis associated with a pharyngitis with a preauricular lymphadenopathy seen in older children, spreads easily by droplet infection by hand contaminated towel and handkerchiefs. Okay, so allergic conjunctivitis, we should be able to differentiate allergic conjunctivitis from a bacterial and viral conjunctivitis. So the typical characteristic feature of a viral or a bacterial conjunctivitis is the presence of matting of the eyelashes. There is matting of the eyelashes. There is a yellow color watery discharge. Mucopurulent discharge is more common in case of a bacterial conjunctivitis. Watery discharge is more common in case of a viral conjunctivitis. The patient will have redness. Pruritus may rarely be seen. But in allergic conjunctivitis, there is no discharge or matting of the eyelashes. The patient typically complains of redness and watering. On averting the eyelid, typically you can make out the presence of papillae on the upper lid. Okay, you'll see the presence of papillae, flat top papillae on the upper lid with conjunctival congestion in allergic conjunctivitis. And in bacterial conjunctivitis, we should know something about the hyperacute conjunctivitis. What is hyperacute conjunctivitis? Hyperacute conjunctivitis is the severe form of neonatal conjunctivitis caused by Neisseria gonorrhea. Okay, Neisseria gonorrhea. So as the infant is delivered through the maternal, during the time of delivery, if the maternal is infected, then there's a high chance of a severe purulent conjunctivitis, which is caused by Neisseria gonorrhea. So it has to be managed aggressively because it can result in a corneal melt and permanent visual loss. Other important causes include Haemophilus influenza and Staphylococcus, typically in children, usually associated with matting of the eyelashes, discharge, mucopurulent discharge, okay, in bacterial conjunctivitis. So coming to the questions, again, you should know something about membranous and pseudomembranous conjunctivitis. So what is pseudomembranous conjunctivitis caused by? Pseudomembranous conjunctivitis is caused by streptococcus. Remember, streptococcus causes a pseudomembranous conjunctivitis. What is the difference between a pseudomembrane and a true membrane? So a true membrane, on removing the membrane, it bleeds, okay? But a pseudomembrane can easily be removed and it does not bleed. There is no underlying bleeding seen in case of a pseudomembrane, but in case of a true membrane, on removal, there is underlying bleeding, and on healing, it forms a scarred cicatron. It scars with cicatrization, resulting in a symblepharon or an ankyloblepharon formation. So always remember, membranous conjunctivitis, if the membrane is peeled, it can result in scarring, resulting in a symblepharon or an ankyloblepharon formation. So which of the following is not a feature of vernal keratoconjunctivitis? Maxwell-Lyon spots, Tranta spots, follicle, perilimbal papillary hypertrophy. So we told follicles are not characteristic of a VKH. Okay, VKH are typically, yesterday we discussed, they are characterized by presence of flat top papillae, presence of Horner Tranta spots, presence of pseudo-gerontoxon, cupid bow-like appearance with conjunctival congestion. Their follicles are not seen in VKH. So the patient has a nodule at the limbus, hyperemia of the conjunctiva, and photophobia. So what are we thinking of? Always remember, this is a presentation of a flectin-lunar conjunctivitis. What is flectin-lunar? Yesterday we discussed it is caused by it is the type 4 hypersensitivity reaction to the bacterial protein, mainly your bacterial, most common organisms are your Mycobacterium tuberculosis and Staphylococcus. So it is a hypersensitivity reaction caused by protein to Mycobacterium tuberculosis, and flectin-lunosis can result in a sacrophilous ulcer. So they can ask you what kind of an ulcer does flectin-lunar conjunctivitis result in. If not treated adequately, it can result in a sacrophilous ulcer. So treatment of flectin-lunar conjunctivitis, remember we start the patient on a course of systemic topical steroids. So topical steroids are the drug of choice in case of flectin-lunar conjunctivitis, because it is an endogenous allergy. Remember, it is the endogenous allergy to the tubercular protein, hence treated with anti-allergic medications along with mild steroids. So where is the sclera thinnest at? Okay, so at the limbus, at the insertion of the extraocular muscle, at the optic nerve. So we know the sclera is thinnest at the insertion of the extraocular muscles. So two organisms frequently involved in flectin-lunosis we discussed yesterday: Mycobacterium tuberculosis and Staphylococcus. Both the protein of Mycobacterium tuberculosis is most commonly implicated in flectin-lunar conjunctivitis. Okay, so hyperacute purulent conjunctivitis, we are talking about hyperacute purulent conjunctivitis caused by Neisseria gonorrhea. Neisseria gonorrhea causes hyperacute purulent conjunctivitis. Why it is hyperacute? Because if it is untreated, it can rapidly progress and result in a corneal melt and corneal perforation. Corneal ulceration, corneal melt and corneal perforation can be a characteristic feature. So the only bacterial conjunctivitis that routinely leads to a preauricular lymphadenopathy. Just now we discussed preauricular lymphadenopathy is a characteristic of a viral conjunctivitis. So which is the only bacteria which produces preauricular lymphadenopathy? It is Haemophilus. Sorry, it is your Neisseria gonorrhea. Neisseria gonorrhea, in addition to causing hyperacute conjunctivitis, can associated with a preauricular lymphadenopathy. Okay, so which of the following is the most appropriate treatment of culture-proven gonococcal conjunctivitis? So the options are 1 gram of ceftriaxone given intramuscularly for 5 days, doxycycline which is given orally for 3 days, topical penicillin G 4 times a day with doxycycline 100 milligrams orally for 1 week, topical penicillin G 4 times a day, and topical tetracycline 4 times a day for 1 week. Last one is ceftriaxone 1 gram daily for 5 days. So remember, we usually give a combination of ceftriaxone and doxycycline. So doxycycline, why is it added? It is added to treat the potential chlamydial infection. So usually hyperacute conjunctivitis is transmitted through the birth canal. So it is transmitted to the infant through the birth canal. It can be associated with an associated chlamydial infection. Hence, we put the patient on oral doxycycline along with ceftriaxone, which is given 1 gram IM. Okay, next question. Classic epidemic keratoconjunctivitis. So we discussed epidemic keratoconjunctivitis typically caused by adenovirus 8 and 19, also known as the pharyngoconjunctival fever. So it is typically associated with fever, pharyngitis, and conjunctivitis. Typically associated with pharyngitis, conjunctivitis, and fever. Can be membranous also. And preauricular lymphadenopathy is a characteristic feature. So you see the presence of preauricular lymphadenopathy, submandibular lymphadenopathy, starts unilateral, severe. Always think of a adenoviral infection. Adenoviral infection, it can present as an epidemic. Hence the name epidemic keratoconjunctivitis, also known as Madrasa in your layman term. Okay, next question. The most important element in the management of a patient with epidemic keratoconjunctivitis: fastidious hygiene, topical trifluviridine, topical bacitracin, topical prednisolone. So prednisolone and trifluviridine are both steroids. Okay, so that is not the most important element. The hygiene is the most important element for preventing the transmission. So any viral conjunctivitis, ask the patient to have a separate set of towel, handkerchief, wash his hands frequently, okay, change his bedspreads. So these are the most common way the which the viral infection usually spreads. Okay, it is highly contagious and it can be transmitted by fomites several weeks after the onset. Okay, so you sleep on a dirty place which is not clean for several weeks, again you can get the infection. Epidemic keratoconjunctivitis usually produces a hemorrhagic or membranous conjunctivitis. Remember, it is a membranous type of conjunctivitis, highly contagious, can be transferred by fomites several weeks after the onset. Next question. Successful long-term management of adult inclusion body conjunctivitis includes oral tetracycline, conjunctival transplantation, examination with treatment if necessary of the contact person. So we usually put the patient on the contacts of these patient must be examined and treated based on the venereal nature, because adult inclusion body conjunctivitis, I told you, is caused by serovirus D2K, chlamydia trachomatis D2K, also known as swimming pool conjunctivitis. So it is a STD. Okay. So the important differences between neonatal inclusion body conjunctivitis and adult inclusion body conjunctivitis include all the following except more prominent follicular response in neonates, more discharge in neonates, more prominent cytoplasmic inclusion bodies in neonates, better response to topical therapy. So he's asked which is not there. So it is follicular response is rarely seen, I told you, in neonatal form, because the follicles take around 4 to 6 weeks to develop. So inclusion body conjunctivitis usually responds well to topical therapy, systemic erythromycin, usually if it is associated with chlamydia infection associated with otitis and pneumonitis. Okay, ear infection and breathing difficulties can also be seen. So with this, we finish the class for today. Tomorrow we'll discuss about the dry eye and test for dry eye.
Good evening all. So as the continuation of yesterday's class, we were talking about the uterine tubes and uterus. Okay, we have talked about the normal position of the uterus. Okay, then today let's talk about the supports of uterus, followed by blood supply of uterus and the lymphatic drainage of uterus, and few important things about the rectum. Okay. So what about the supports of the uterus? Yes, you know the uterus is supported by numerous neighboring structures like muscles, ligaments, okay, and neighboring viscerae. Okay. So the supports of uterus can be divided into two types. Okay. Primary supports of the uterus and secondary supports of the uterus. Obviously, primary supports are the main or true supports of the uterus. What about secondary supports? As the name indicates, they are weak or false supports. Whether they are really providing support to the uterus is highly doubtful. Okay. So in the secondary support of the uterus, just to remember only one ligament. Okay. That is broad ligament. Okay. Broad ligament is not at all providing support to the uterus. Okay. Fine. So that is the thing. And remember, in the secondary support, if the broad ligament is not given, okay, then the answer will be round ligament. Okay. If you see this slide, you will be able to see under primary supports, you will be able to see the round ligament of uterus, isn't it? But actually, some books are mentioning round ligament also as secondary support. Okay. So all the following ligaments are primary supports except, otherwise, which of the following is a secondary support of the uterus? Like that question is there, means if broad ligament is there, that is the answer. If it is not found among the options, then you can go for round ligament of uterus. Fine. So what are the primary supports of the uterus? Yes, there are 3 muscular supports, there are visceral supports, and 4 ligaments providing support to the uterus. Okay. So what about the muscular supports of the uterus? What about the muscular supports of the uterus? Yes, one is called as pelvic diaphragm, then urogenital diaphragm, then perineal body. Okay. So why they are called as muscular supports? Obviously, they are made up of muscles. Okay. What are the 2 muscles forming the pelvic diaphragm? Levator ani is the main muscle forming the pelvic diaphragm, and also another muscle forming the pelvic diaphragm is coccygeus. Levator ani and coccygeus. These are the 2 muscles forming the pelvic diaphragm. Okay. Actually, this is the most important support of the uterus, pelvic diaphragm. And what about urogenital diaphragm? Yes, it is also made up of 2 muscles. One is deep transverse perineal muscle. Okay, deep transverse perineal muscle. Another one is sphincter urethrae muscle, otherwise known as external urethral sphincter. Sphincter urethrae muscle, also called as external urethral sphincter. Okay. And what about perineal body? Perineal body is made up of 10 muscles. Actually, it is formed by the insertion of 10 muscles. We have a separate class for the perineal body. We will discuss the 10 muscles, okay, later. Fine. So these are the various muscular supports. Visceral supports, as we know, uterus is resting over the superior surface of the urinary bladder. Okay. And the normal uterine axis also provides one important support to the uterus. Okay. And I hope you will be remembering the definition and the normal angle of anteflexion and anteversion. Okay. Yesterday we have discussed, right? Okay. Coming to the primary ligaments providing support to the uterus. The most important ligament providing support to the uterus is transverse cervical ligament. Okay. The most important ligament providing support to the uterus is transverse cervical ligament. What is the another name for the transverse cervical ligament? Yes, it is also called as McEnroth's ligament. McEnroth's ligament, otherwise cardinal ligament of uterus. Cardinal ligament of uterus. Okay. From the name itself, you can easily guess what is the extent. What will be the extent of transverse cervical ligament? Yes, they are extending from the lateral walls of cervix towards the lateral pelvic walls. Okay, towards the lateral pelvic walls. Fine. Okay, fine. Now, what are the other primary ligaments of uterus? Uterosacral ligament, pubocervical ligament. Okay, from the name you can guess, from uterus to the sacrum bone, you have the extent of uterosacral ligament. Pubocervical ligament extends from pubic bone to the cervix of uterus. I told you already regarding the round ligament. Okay, the round ligament can be considered as a secondary support. Okay, fine. Because it is not attached to bony landmarks. Okay, it is not attached to bones. It is passing through the inguinal canal in females from the deep inguinal ring to the superficial inguinal ring. Once it comes out of the inguinal canal, it is attached finally to the external genital part called as labia majora. Okay, fine. Now, this diagram is showing the three primary ligaments of the uterus. Okay, this is the cross section of the female pelvis. In this diagram, you will be having the orientation of which is anterior, which is posterior, isn't it? So anteriorly, you are able to see the pubic symphysis. Posteriorly, we have the sacrum bone, isn't it? So urinary bladder. Behind the urinary bladder, we have the cervix of uterus. Behind that, we have the rectum. So the names of the ligaments you can understand: uterus to the sacrum bone, uterosacral ligaments. Extending transversely from the cervix of the uterus towards the lateral wall of pelvis, we have the transverse cervical ligaments, these two. Okay. And extending from the cervix towards the pubic bone, we have the pubocervical ligaments. Fine. So all these three you are seeing here, transverse cervical ligament, uterosacral ligament, pubocervical ligament, these are primary ligaments supporting the uterus. Okay. The most important ligament providing support to the uterus is this one, transverse cervical ligament, also called as McIntyre's ligament or cardinal ligament of uterus. Okay. Yes, now we have studied among the secondary supports of uterus, we have studied one ligament, namely broad ligament, secondary support. Okay, so can you see the broad ligament in this diagram, which is labeled as BL, broad ligament? Okay, so you are seeing the uterus. Okay, you are seeing the uterus. You know the three parts of the uterus from above downwards, isn't it? Fundus, body, cervix. Okay, so from the body of the uterus, there are two ligaments extending horizontally, transversely, called as broad ligament. Okay, fine. Broad ligaments extend both sides from the body of uterus. Fine. Okay. And you can see the green color structure, both sides of the cervix, called as transverse cervical ligament. Transverse cervical ligament. Okay. Now, what are the three parts of the broad ligament? Okay, according to the site of attachment, the broad ligament consists of three parts. What are they? Yes, one is called as mesosalpinx, which is attached to the fallopian tube, so called as mesosalpinx. Another one is attached to the body of uterus, as we have seen in the previous diagram, that is called as mesometrium. Another one is mesovarium, which is attached to the ovary, which is attached to the ovary, mesovarium. Okay, fine. These are the three parts of broad ligament. Fine. And it is a secondary support or false support or weak support of the uterus. Fine. Okay, now coming to the contents of broad ligament. Okay, what are the contents of broad ligament? You can remember, if you want, you can remember by using this mnemonic. Okay, fur rope, FURROP, fur rope. Okay, so F is representing the fallopian tube. Okay, fallopian tube. Then U and O representing the uterine and ovarian vessels and nerves. Uterine and ovarian vessels and nerves. Okay, what about the two R? Yes, one is called as round ligament of uterus. Another one is round ligament of ovary, or simply called as ligament of ovary. Ligament of ovary. Okay. Then what about P and E? They are the embryological remnants. Okay, embryological remnants located within the broad ligament called as paraoophoron and hypoophoron. Paraoophoron and hypoophoron. Okay. So these are the various contents of the broad ligament. Okay. Please remember these two structures I am marking now. Ovary and ovaries and ureters both are not located within the broad ligament. They are not located within the broad ligament. That means they are not contents of broad ligament. Okay. So this repeatedly asked the question. All are contents of broad ligament except. So ovaries and the ureters both are not contents of broad ligament. Fine. So coming to the blood supply of the uterus. Okay. You know. Okay. The uterus is mainly supplied by, obviously what? Mainly by uterine artery and partly by ovarian artery. Okay, mainly by uterine artery and partly by ovarian artery. Fine. So regarding uterine artery, the points we have to remember, it is a branch of anterior division of internal iliac artery. Okay, uterine artery is a branch of anterior division of internal iliac artery, and it is one of the arteries in our body having a tortuous course. Okay, tortuous course. And this uterine artery, after reaching the lateral border of the cervix, it is ascending along the body of uterus within the broad ligament. Finally, it ends by anastomosing with the ovarian artery. You can see in this diagram. Okay, this is the uterine. Okay, sorry. This is the uterine artery. Okay, uterine artery, after reaching the lateral walls of the cervix, it starts ascending. Okay, along the body of the uterus within the broad ligament. Okay, after supplying the vagina, then the uterus, after supplying the medial 2/3 of the fallopian tube. Okay, medial 2/3 of fallopian tube. Finally, what happens to the uterine artery? Yes, it ends by anastomosing with ovarian artery, branches of ovarian artery. Okay. So all these structures are supplied by uterine artery. Uterine artery not only supplies uterus, it also supplies vagina, medial 2/3 of the uterine tube, and also you can see it will be supplying a part of the ovary called as ovarian branch of uterine artery. Okay. So uterine artery gives branches to supply vagina, uterus, medial 2/3 of fallopian tube, and also a part of ovary, right? Yes. And as we know, just lateral to the cervix of the uterus, uterine artery is closely related to which structure? Ureters, isn't it? So what is the importance, isn't it? You can see in this diagram. Actually, this diagram is showing the cross section of female pelvis. So anteriorly, you are seeing the bladder, then behind that cervix of uterus, behind that rectum. Okay. So the ureters within the pelvic cavity, the ureters on the way to reach the urinary bladder. Okay. The ureters are crossed by the uterine artery superiorly. We are seeing from above, okay, superiorly from lateral to medial side. That's what I have written here. Uterine artery is closely related to ureters. Uterine artery crosses the ureter superiorly from lateral to medial side. The importance, as all of us know, during hysterectomy, when you ligate the uterine artery, you have to take care of the ureters. Okay, if there is accidental injury to the ureters during ligation of uterine artery, there may be extravasation of urine. Okay, fine. Now coming to the venous drainage, obviously uterine artery is a branch of internal iliac artery. Correspondingly, the uterine vein will drain into internal iliac vein. Then coming to lymphatic drainage of uterus. Okay, so the fundus, the topmost part of uterus, drains into para-aortic nodes. From the body, the lymph drains into external iliac nodes. From the cervix of the uterus, what are the lymph nodes which receive lymph from the cervix of uterus? Cervix of uterus drains into 3 or 4 nodes. Okay, the 3 main nodes are ESI: internal iliac, okay, external iliac, and sacral nodes. Internal iliac and external iliac, then sacral nodes, and sometimes the lymph from the cervix may also drain into obturator nodes. Fine. So majority of the times the question will be asked related to the lymphatic drainage of cervix of uterus, right? So you can see in this diagram, this is the fundus of uterus. Okay, this is the fundus of uterus which drains into the pre and para-aortic nodes. From the body of the uterus, the lymph is draining into external iliac nodes, What about the cervix? Yes, lymph from the cervix of uterus drains into, okay, internal iliac, external iliac, and also into the sacral nodes, and sometimes it may also drain into obturator nodes. Fine. Okay, fine. Now, followed by the uterus. Next few minutes, let's talk about the rectum. Okay, let's talk about the rectum. Okay, fine. So, rectum is located in the pelvic cavity. Okay, similar to the urinary bladder and uterus, rectum is also pelvic organ, which is about 12 centimeter long. Okay, approximately 12 centimeter long, isn't it? It is the distal part of the large intestine. Distal part of large intestine. Okay, fine. So the things about the rectum is, rectum is located just in front of sacrum bone, just in front of sacrum bone as well as coccyx bone. So what is the site of beginning of rectum? This question has been asked. Okay, what is the site of beginning of rectum? Yes, S3 vertebra. Rectum begins in front of third sacral vertebra. Third sacral vertebra, S3. Okay, S3, third sacral vertebra. That means rectosigmoid junction is located at the level of S3 vertebra. Okay, then at the level of tip of coccyx, it continues downwards as anal canal. Rectum continues as anal canal at the level of tip of coccyx. Right? Okay. And the two more important topics of the rectum, one is peritoneal relations of rectum, another one is blood supply of rectum. Okay, peritoneal relations of rectum and blood supply of rectum. Okay, so peritoneal relations, blood supply of rectum, and regarding the anal canal, let's discuss in tomorrow's session. Okay, tomorrow's session. Thank you all.
So good evening. So today's topic is apoptosis, isn't it? Yesterday we ended the class with a MCQ on apoptosis. So we will see in detail what is this apoptosis or apoptosis. Okay, you can pronounce it either way. Apoptosis. Okay, so briefly introducing apoptosis about whatever points are important for our MCQ, to speak about those points. Apoptosis, okay, it's an active process. It is an active process. Okay, next, it is energy dependent. It is energy dependent. When I say energy dependent, okay, that means you have to understand mitochondria is involved. Okay, then next one, it is programmed. It is programmed cell death. Apoptosis is a programmed cell death. It is active process, energy dependent. And see, it is not like necrosis. The entire tissue is not going to undergo apoptosis. It is at the cellular level, that is individual cells. Individual cells. We solved an MCQ on this, isn't it? Individual cells undergo. So the cell will individually undergo apoptosis. This cell will individually undergo apoptosis. It's not a tissue undergoing necrosis. Okay. So that one you have to know. Now this apoptosis can be physiological and pathological. Okay. So when going to physiological and pathological, the examples are so physiological is during embryogenesis. Fine. There are few organs which have it in the embryo itself, that is embryogenesis. What happens there is loss of growth factor. That is a signal for the cell to undergo apoptosis. Okay. Next one, turnover of proliferative tissues like intestinal epithelium, lymphocytes in bone marrow, and thymus. So that is also, there is loss of growth factor signaling. So they undergo apoptosis. Okay. Then involution of hormone dependent tissues like endometrium. Yesterday we solved a question on menstruation, isn't it? So that is based on here the growth, instead of the growth signals, here it is the hormone levels, fall in the hormone levels are going to cause apoptosis or induce apoptosis. Okay. Decline of leukocyte numbers at the end of immune and inflammatory response. Say, for example, the body is responding to some inflammation or infection. So later, the immune system should calm down. The inflammatory cells should fall down once the infection is gone. Otherwise, it will be damaging the self tissue, isn't it? That also. So there's loss of survival signals for that particular leukocyte. Elimination of, this is an important question, elimination of potentially harmful self-reactive lymphocytes, that is energy, isn't it? Energy, that is to prevent autoimmunity. Fine. So these are the physiological conditions. Pathological conditions, DNA damage. Whenever there is a DNA damage, the stress proteins, BH3 sensor proteins are getting activated. Accumulation of misfolded proteins. Okay, infections, especially viral infections, hepatitis. You have to remember that the process by which the cell is destroyed is apoptosis. Okay, the process by which the cell is destroyed is apoptosis. Okay, misfolded proteins, chemotherapy, DNA damage, and whenever we give chemotherapy, that also you have to remember, important. And one more thing is when tumor cells and graft cells, okay, grafted cells, they also undergo apoptosis. So these are the examples of physiological and pathological. So though it's very basic, important, you all know it is repeatedly asked. Okay, fine. So basically in apoptosis, what happens is morphology. When we come to the morphology of apoptosis, what happens is the cell undergoes shrinkage. First thing the cell undergoes is shrinkage. So the early sign, if they ask you, it is cell shrinkage. Okay. And then what happens to the chromatin inside? It undergoes condensation. The chromatin undergoes condensation. Okay, condensation of chromatin. Fine. After that, one more important important point is, see, these cytoplasmic blebbings are formed. Okay, if the particular cell, whichever is to undergo apoptosis, cytoplasmic blebbings are formed, and in those blebbings, okay, that plasma membrane is going to encircle some amount of cytoplasm with few organelles, and these plasma membrane bound cytoplasm with organelles is called apoptotic body. So nowhere we see there is a breach in the plasma membrane or leak of cytosolic components. Okay, that is why there is no inflammation. There is no inflammation. Important point. So there is no inflammation. Okay, and there is quick phagocytosis of this apoptotic bodies. Okay, there is quick phagocytosis of this apoptotic bodies. Okay, fine. Now in your Robbins 10th edition, one new thing they have put up. Okay, the word is inserted for the first time. Okay, so what is that? Efferocytosis, important for your MCQ. What is this efferocytosis? Okay, apoptotic bodies are well coated. Okay, are well coated with natural antibodies of complement system, notably C1q. Okay, whatever I tell is important. So these apoptotic bodies will become coated, will be coated with C1q, and that is nothing but eat me signals. Okay, and it will induce eat me signals on these apoptotic bodies. And then these are quickly recognized by phagocytes and they're engulfed. These apoptotic bodies are engulfed. This process of apoptotic cell getting phagocytized is called efferocytosis. Okay, it's a special type. It is so efficient that it occurs within minutes. Okay, so because it is occurring within minutes, there is no inflammatory reaction. Along with that, one more thing is, in addition to production of pro-inflammatory cytokine, in addition to this, there is reduced production of pro-inflammatory cytokines. So what you have to remember here is, what is efferocytosis? It is nothing but phagocytosis of the apoptotic bodies. Okay, and why is it getting phagocytized? These apoptotic bodies are coated by C1q, and these apoptotic cells express eat me signals, and that is why these phagocytes come. Okay, and because these apoptotic bodies are plasma membrane bound, first point, plasma membrane bound, first point. Okay, these are membrane bound. Second thing is, this phagocytosis is occurring very, very quickly. Okay, so very quick. And these, that is efferocytosis, these phagocytes which are going to take part are going to produce less amount of pro-inflammatory cytokines. So all these three are going to contribute to no inflammation in apoptosis. So your question will be like, the following are the reasons for no inflammation in apoptosis. First thing, plasma membrane. Next one, very quick or efferocytosis. Third one is less amount of pro-inflammatory cytokines produced by the macrophages. Okay. If the option all the above is given, you have to mark that. Fine. You understood? Efferocytosis. Very good. Next, I told you morphology, there is cell shrinkage. See, this is colonic biopsy. Okay. If you see the amount of cells which are concentrate on these three cells, and see the chromatin, it has become more dense. The chromatin has become more dense, and the cell is shrunken compared to the cell size of others. The cell is shrunken and the chromatin is dense. Okay, civet bodies is also an example for apoptotic bodies. Civet bodies, okay, in the skin. Okay, and then Councilman bodies. Councilman bodies in case of viral hepatitis. Councilman bodies in case of viral hepatitis. So all these are examples of apoptosis or apoptosis. Next thing is, what are the biochemical changes? We'll see. What are the biochemical changes? So which is the earliest change? I told you cell shrinkage. What are the biochemical change? Hallmark of apoptosis is, hallmark is caspase activation. Caspase activation. Okay, so in all the tissues, it is the caspase activation which is the hallmark of apoptosis, except in nervous tissue, where apoptosis inducing factor is there instead of caspase. Okay, there is no caspase in neural tissue. It is apoptosis inducing factor. Okay, so the hallmark is caspase activation. This caspase is an enzyme. Okay, this caspase will induce another enzyme called endonuclease. This endonuclease is going to cause internucleosomal fragmentation of DNA, leading to small fragments comprising of 180 to 200 base pairs. That is why we see the step ladder pattern. I showed it to you in the previous MCQ, isn't it? Step ladder pattern on agarose gel electrophoresis. So this is the hallmark of biochemical reaction. And if they ask you a marker of apoptosis, so what happens in apoptosis is, in the cell membrane, plasma membrane, there is flipping. Okay, there is flipping up of phosphatidylserine. Flipping of phosphatidylserine. So when there is flipping of phosphatidylserine, what will happen is the phosphatidylserine is exposed outside, and to this a specific marker, annexin 5, will bind. So which is the marker for apoptosis? It is annexin 5. So this is the marker for apoptosis. Why it's a marker? Because there is flipping of phosphatidylserine from the inner surface to the outer surface of the plasma membrane, which is of the cell which is undergoing apoptosis. Right? Now coming to the pathways. Excuse me. Now coming to the pathways, one thing we have to observe. I'll just tell you what happens. Okay. See, apoptosis. Okay, it has initiation. It is and execution. So this process has two steps, initiation and execution. This initiation can be further divided into two types. Okay, initiation and execution are two steps. Initiation can be two types: intrinsic pathway, extrinsic pathway. This intrinsic is otherwise called mitochondrial pathway. Okay, and extrinsic is called death receptor pathway. Then later, be it intrinsic or extrinsic, both will lead to executional pathway. In all these pathways, caspases are going to play an important role, but the caspases are different in different things. So in executional pathway, it is caspase 3, 6, and 7. In initiation, if it is occurring through intrinsic pathway, it is caspase 9, and if it is occurring to extrinsic, it is caspase 8, and in case of humans, it is caspase 10. Okay, we have something called genes also controlling. So apoptotic genes and anti-apoptotic genes. So what are the apoptotic genes? What are the apoptotic genes? Very, very important. This, you know, okay. See, it is BAC, BCL-XS, okay, it is XS, and BH3 sensor proteins, BID, BAD, Puma, Noxa. So these are the apoptotic genes and proteins. Anti-apoptotic BCL2, MCL1, BCL-XL. XS is apoptotic, XL. So it's allowing the cell to excel. Okay. So these, how do I remember is MCL1, everything ends with L. Okay, that is one thing. MCL1, BCL2, and then BCL cells. That is how I remember. See, this MCL1, when it is activated, when this gene is activated, when it is anti-apoptotic, okay, that is the gene which is going to play a role in drug resistance in case of chemotherapy. Okay, drug resistance in case of chemotherapy. One more important point in this apoptosis is, we'll see the pathways tomorrow, but one more last important point about apoptosis is when the cells lose adhesions, also they undergo apoptosis. Okay, when the cells lose adhesion in the tissue, they undergo apoptosis, and that is called anoikis. Ames question, and that is called anoikis. Okay, genes are Ames questions. Caspases, which occurs, which is there involved is questions. Okay, anoikis. Right? Okay, so we'll see the pathways and related MCQs tomorrow. Thank you.
We'll discuss food poisoning today, a very, very important topic for your entrance exam. You get a multiple question on this topic. So this topic is very, very important. So we'll start discussing with organism, how will be their presenting symptom, and what are the food sources for these infections. So every organism or every toxin has different incubation period for their clinical presentation to appear, right? So which all toxin will show the symptom? Which all toxin will show the symptom in 1 to 6 hours? Okay, so you have two in this group, either Staphylococcus aureus or Bacillus cereus. These two are the organism. Their toxin will show the sign and symptom in 1 to 6 hour duration. And how the clinical presentation of these patients will be, they will present with Staphylococcus aureus, vomiting, diarrhea, abdominal cramps. Mainly the vomiting, nausea will be main symptoms. Diarrhea might be associated with abdominal cramps. So what are the food sources for Staphylococcus aureus food poisoning? Poultry products, salad, pastries, milk and milk product, mayonnaise. These all are the food source for Staphylococcus aureus food poisoning. Right? Bacillus cereus, we'll discuss later. You have emetic type and diarrhegenic type. So patient will be presenting, a person will be presenting with vomiting, diarrhea and cramps. And what is the food source? Most common food source is fried rice. Okay. Now coming to 8 to 6 hour incubation period. So you have Clostridium perfringens. Okay. Patient will present with diarrhea and cramp, abdominal cramp. Beef, poultry product, legumes, gravies, these all will be source for Clostridium perfringens. Okay. Bacillus cereus. Okay. The diarrheogenic type, this was emetogenic, which comes within 1 to 6 hours. Diarrheogenic type will present with abdominal cramps and diarrhea. The sources are meat, vegetables, dried beans, and cereals. Now coming to the, so we learn 1 to 6 hours, less than 6 hours, that is 1 to 6 hours, then 8 to 16 hours, then more than 16 hours incubation period. So you have Vibrio cholera, patient will present with watery diarrhea. What is the most common source? It's shellfish and water. So seafood, okay? Enterotoxigenic E. coli, watery diarrhea, salads, cheese, meat. These all will be the common water. These all will be common source of food poisoning. Enterohemorrhagic E. coli. Hemorrhagic E. coli will present with bloody diarrhea. So what are the food source? Beef, salami, milk, raw vegetables, apple juice are the food product. Now coming to non-typhoidal salmonella, which causes inflammatory diarrhea. Meat, egg, milk, juice, raw vegetables are the source. Shigella will present with dysentery, Shigella dysentery. So what are the source? Potato, egg salad, lettuce, raw vegetables. Vibrio parahemolyticus will also present with dysentery. Dysentery is nothing but your stool mixed with blood and mucus is called dysentery. So parahemolyticus, raw or undercooked shellfish and oysters. So this also seafood. Campylobacter jejuni will also present with inflammatory diarrhea like your non-typhoidal salmonella. Here the food source will be poultry, raw milk and water. Now coming to Clostridium botulinum, child or patient will present with flaccid paralysis, with diplopia and dysphagia. What is the common source? Improperly stored canned food, honey, especially in the infant. Then Listeria monocytogenes will present with fever and myalgia. Listeria only the food poisoning you see in pregnant women. Cheese, sprout, meat, seafood, and milk are the source of infection. Mycotoxin, that the incubation period might differ from 6 to 24 hours. Fungal toxins, aflatoxin is the most common fungal toxin which causes food poisoning. Nuts, maize, wheat, cereals are the source of infection. Now, norovirus will present with watery diarrhea, vomiting, abdominal cramps. And what is the food source? Salad, fresh fruit, shellfish, and water are the food source. So please remember these all incubation period, organism, because you get a question, right? In NEET 2021, you got a question that a few of the friends ate late night pastry and early morning they started presenting with nausea and vomiting. What can be source of infection? So late night they ate, early morning, so we are expecting incubation period less than 6 hours, and the history was person had person ate pastry. So you can see here Staphylococcus aureus, pastry presenting with vomiting, nausea. So the answer there will be Staphylococcus aureus. Okay. Now coming to Staphylococcus, we'll learn all food poisoning one by one now. Okay. Moving to Staphylococcus food poisoning, a very common question which is asked. What is the toxin which causes Staphylococcus food poisoning? So it is enterotoxin, which is preformed toxin which is already present in the food. It's not like you have eaten the food and toxin is secreted inside the intestine. It's already present outside in the food, and that food you have consumed, that is your preformed toxin. Okay, how it acts? It acts on the vagus nerve and vomiting center. It acts on the vagus nerve and vomiting center of the brain. So patient will have nausea and vomiting as a presenting complaint more than diarrhea. Diarrhea might or might not be. Okay. So sources are food handlers, contaminated hand of food handlers. What is the toxin? This preformed toxin is actually a super antigen, okay? And these are heat stable toxin resistant to gastric juice. It does not get destroyed even with heating. So these are heat stable and they act as a super antigen. They have A to E and G to P, total 15 serotypes. Okay, and you detect by ELISA and PCR. Treatment will be just fluid and electrolyte replacement. So we'll read a question. Now we'll try to solve it. The following are characteristic feature of Staphylococcus food poisoning except optimum temperature for toxin production is 37 degree. Okay, so fine, yes. Optimum temperature is 37. That is your body temperature or room temperature, you can say. Intradiatic toxin is responsible for intestinal symptom. Yes, it is preformed. It's present inside the diet. Toxin can be destroyed by boiling for 30 degrees centigrade. No, it cannot be. Why? Because these are heat stable toxins. Incubation period 1 to 6 hours. Yes, it's right. So the wrong answer here, it does not get destroyed by boiling because these are heat stable toxin. Right? Now moving to next. A person, Chinese restaurant syndrome, after eating fried rice, Chinese fried rice, or with vanilla sauce. What can be the cause? Clostridium perfringens. We'll just go and check. Does the Clostridium perfringens has these all food source? No, it's mainly beef, poultry, legumes. So this we are ruling out. Now we'll see Bacillus cereus. Does the fried rice is a source of Bacillus cereus food poisoning? Yes. Fried rice is a source of Bacillus cereus food poisoning. Now, Staphylococcus aureus, we saw like pastries, milk and milk products, poultry products. Clostridium botulinum, we saw, right? It was honey and canned food and honey, two very important source for Clostridium botulinum. So it is Bacillus cereus. Please remember Chinese fried rice, eating in a Chinese restaurant, Bacillus cereus food poisoning. Okay. So Bacillus cereus, as I was telling you earlier, Bacillus cereus has two type of toxin, diarrhegenic type and emetic type. Okay. So incubation period for diarrhegenic is longer, 8 to 16 hours. Fine. Emetic type is 1 to 5 hours or less than 6 hours, you can say. Toxin will be secreted in intestine. Here toxin will be preformed in the food. Diarrhegenic is heat labile. If you cook the food properly, it will be destroyed. Okay. Or it is heat labile, you can say. It is heat stable. It does not get destroyed with heat. Food is meat, vegetable, dried beans, and cereals. So vegetables, meat, and cereals as the cause. Here Chinese fried rice is the cause. Clinical feature, diarrhegenic will present with fever, diarrhea, abdominal cramps. Here vomiting and abdominal cramps. So they have 2, 6, 8, 9, 10, 12 is the serotype, which is diarrhegenic. 1, 3, and 5 is emetic type. Now, Apart from this, it can present as a keratitis, panophthalmitis, systemic infections like endocarditis, meningitis, osteomyelitis, this pneumonia, this all can be clinical presentation. Culture media is will have mannitol, agar, polymyxine, phenol, red agar. These all be constituent of culture media which grows Bacillus cereus. What is the treatment of choice? Clindamycin, erythromycin, tetracycline, vancomycin are the drug of choice for the treatment. They are resistant to penicillin because they produce beta-lactamase. So they will show resistant to penicillin. Now, any food poisoning, not only Bacillus cereus, any food poisoning, how you diagnose it? So first you will do the food sampling. You will take the food sample and examine for the toxins, preformed toxin. You will culture, you will look for the count, viable plate count, or enrichment media culture you can do, or toxin detection by ELISA or PCR, different techniques you can use. Now moving to botulism, which is caused by Clostridium botulinum, which is nothing but a gram-positive spore-forming bacilli. Name is derived from Latin word, which is botulus, means sauces, because that was the most common source of botulinum food poisoning. They are powerful, very, very powerful neurotoxins. Okay, neurotoxin. They have 8 serotypes: A, B, C1, C2, D, E, F, G. So A to G, and C will have C1 and C2. Which is the most common type is your A, B, E. Which is the most dangerous type is A. This is one of the exotoxin which is not secreted outside cell, but they are intracellular. And this toxin is bacteriophage coded and causes the symptoms of presenting feature will be flaccid paralysis. And it will resemble strychnine poisoning. So here is an 18-year-old male coming with acute onset of descending paralysis of 3 days duration, fine. And he also gives history of blurring of vision, quadriparesis with areflexia, pupil are non-reactive. So what is your diagnosis? Diagnosis can be your botulinum toxin. Why I'm saying? Okay, because we saw the presenting feature, right? They present with flaccid paralysis and other. I will restart. Okay, so we'll just see the mechanism of action, how Clostridium botulinum toxin acts. So they acts on this, you can see. So how acetylcholine gets released and they bind to, at neuromuscular junction, they bind to nicotinic receptor. So what this botulinum toxin does, they go and bind to this acetylcholine. Okay. So this acetylcholine are not released. So postganglionic, parasympathetic and peripheral ganglia, directly they does not act on central nervous system. So they block the acetylcholine release. Okay, then patient will presenting with descending symmetrical flaccid paralysis. You can see the hypotonia in a child. Plus diplopia, double vision, dysphasia, dysarthria, decreased deep tendon reflexes, respiratory paralysis, floppy child syndrome. This is the floppy child syndrome. Okay. These all will be the presenting feature of botulinum toxin. So we can solve this. descending flaccid paralysis, blurring of vision, diplopia is there, areflexia is there, pupil is not reactive. So this all is the feature of botulinum toxin. Okay. So food-borne botulism, wound botulism, or infant botulism. All botulism can be classified into 3 types. So food-borne is because of preformed toxin in a food. Okay. Mainly the canned food, improperly canned food. Okay, fermented food. Wound botulism is because wound contaminated with the spores of Clostridium botulinum. And infant botulism is because of contaminated honey, especially seen in the infant. Okay. So we conclude today class. Hope the class was useful for you. We'll meet again with some interesting topic. Thank you.
Moderator, just confirm, am I audible? Moderator, just confirm, am I audible? Moderator, please confirm, am I audible? Okay, coming to today's class. Good evening, guys. So we were seeing endocrinology. Maybe we'll little break from endocrinology for today and tomorrow. Today we will see local anesthetics, and tomorrow we will see skeletal muscle relaxants, because these are high yield topics. Usually they ask a lot of questions from this. So I just wanted to give a break from endocrinology and do this, because endocrinology, you have to understand the concepts, because totally it is hormone. So let's just break and let's go into local anesthetics. See, this local anesthetics, it depends upon the type of fibers. So I have mentioned here something called as the order of block. So if you see the order of block, type B and C are small fibers, whereas type A is large fibers. What is that? Type B bar C is small fibers. Type A is large. So type B and C are the first to get blocked, whereas A, delta, beta, gamma, alpha follows the order. With respect to autonomic, with respect to the systems, autonomic system will first get blocked, followed by sensory, followed by motor. Recovery is just exact reverse of that. So if you see here, A fiber, type A is the last to recover. Type A is the last to recover. Whereas here, motor, sensory, and autonomic. With respect to individual pain, temperature, cold, deep pressure, pain is the first to get blocked with anesthesia. Then comes your cold temperature, followed by heat. Then touch. Then deep pressure. Then proprioception. When you tell in surgery, patient is going to be cut first, so pain is gone. Cautery is used. So cold cautery, you will not feel. Heat cautery followed. Then touch when surgeon does. Then deep pressure, deeply when he operates. Then proprioception. So this is the order of block. So that's why I have written here, small fibers and myelinated fibers are blocked more than large fibers and unmyelinated fibers. It means MCQ can be asked in such a way that small fibers and myelinated fibers are more getting blocked with local anesthesia. See, there are two types, amides and esters. Amides are usually longer acting, whereas esters are usually shorter acting because these are metabolized by esterases. Amides have less allergy, whereas esters have more allergy. And esters also antagonize sulfonamides because they can degrade the PABA, BABA. Okay. So now coming to how to differentiate between amide and esters, you need not mug it up. Okay. If your anesthetic has 2I, lignocaine, 2I, all the anesthetic names that has 2I are amides. All the anesthetics that has only 1I, cocaine, are esters. Among the amides, dibucaine is the longest acting. Remember this. Dibucaine is the longest acting. Lignocaine is the most commonly used. Bupivacaine is the most cardiotoxic. Most common, most cardiotoxic. Whereas chlorprocaine is shortest acting in case of esters. All the local anesthetics, okay, fall into one group except for cocaine. It is a sympathomimetic. Sympathomimetic. So all the local anesthetic can cause vasodilation, whereas cocaine will cause vasoconstriction. Next slide, I'll tell you. After mechanism of action, I have put that slide. So mechanism of action, how does? See, usually this acts on sodium channels. This local anesthetics will block your sodium channels. But how does it block? See, first it will penetrate the sodium channels in the unionized form. That is axonal membrane. It will penetrate. So when it goes inside, it will get ionized, and this ionized form will go attached to your sodium channel and keeps the channel in blocked state. So unionized ions go inside, becomes ionized, and then they block the sodium channels. Sodium bicarbonate, if you give, it will increase the unionized forms because base in base, it will increase the unionized forms. Unionized forms means more penetration, more block. Local anesthetic to increase the action, to decrease the toxicity, you can add adrenaline. Remember this, you can add adrenaline. Felipressin can reduce the serious complications that can be associated with adrenaline. So in case a patient is having serious related things, you can use felipressin instead of adrenaline. Okay. Lignocaine and adrenaline, where not to use? Where not to use? Areas with end arteries. Yes, ring blocks for fingers. End arteries, it might get vasoconstriction. Gangrenes might happen. So do not use. With halothane, it can increase myocardial sensitization with adrenaline. So do not use. MI patients don't use lignocaine and adrenaline. Hyperthyroid patients do not use. Severe hypertensives, vasoconstriction can lead to increase in hypertension. Do not use. Intravenous regional anesthesia, that is in Beer's block, you don't use adrenaline with lignocaine. Okay, we have a different anesthetic choice for that. So lignocaine and adrenaline cannot be used in areas with end arteries with halothane because myocardial sensitization is increased in MI patients, in hypertensives and hyperthyroid patients, and also in Beer's block. Now, golden points you have to note. What is this? Golden points. We already saw small diameter axons most frequently blocked. Myelinated fibers more sensitive. All local anesthetics are vasodilators except cocaine, which is sympathomimetic because cocaine inhibits what? Noradrenaline reuptake. It means more noradrenaline is going to be available. So vasoconstriction can happen. Cocaine never in IV with adrenaline. It can cause more vasoconstriction. So do not use. Cocaine ester not metabolized by pseudocholinesterase. All esters with single I. All anesthetics with single I. These are esters. No, they are metabolized by pseudocholinesterase. That's why I told esterases, right? But cocaine alone is metabolized by liver. Okay. Procaine is the anesthetic of choice for malignant hyperthermia. Remember this. Procaine is the anesthetic of choice for malignant hyperthermia. Chlorprocaine, especially, it has a substance that is called a sodium metabisulfate as a preservative. So do not use this. If this sodium bisulfate is found in chlorprocaine, because it is contraindicated in spinal anesthesia because it can cause paraplegia. The sodium bisulfate is neurotoxic. All local anesthetics, excitation, first they excite the CNS followed by depression. That means low doses, it can cause seizures, and high doses, it can cause coma. Dibucaine, I told you, it's the longest acting amide. It's most potent as well. It's most toxic as well. Okay. Lignocaine is a drug of choice for ventricular tachycardias. Lignocaine can cause malignant hyperthermia due to excess calcium release. Remember this can be an MCQ. Dose of lignocaine, when used with adrenaline, use a high dose, 7 mg per kg. When without adrenaline, use 4 mg per kg. Remember it. So golden point, small diameter, myelinated, more sensitive, all local vasodilators except for cocaine, sympathomimetic, not used with adrenaline. Esters, all metabolized by esters, all esters except for cocaine, is metabolized in the liver. Procaine, drug of choice for malignant hyperthermia, whereas lignocaine can cause malignant hyperthermia. Is a drug of choice for ventricular tachycardias, lignocaine. Chloroprocaine, sodium bisulfate, neurotoxic, it can cause spinal anesthesia, so it can cause paraplegia, so contraindicated in spinal anesthesia. Seizures at low dose and common, and coma at higher doses is very common with anesthetics. Dibucaine, not only the longest, but also the most potent as well the most toxic. Bupivacaine is a drug of choice for regional block. That's what I told, no, lignocaine cannot be used. So it's Beer's block. It's more useful. Okay. It's the most cardiotoxic. So do not use bupivacaine for Beer's block. Do not use. For regional blocks, you can use bupivacaine. For Beer's block, we have one more drug, which is prilocaine. Okay. Which is prilocaine. More suitable for Beer's block. For bupivacaine, the choice is mainly for regional blocks. Adrenaline, no effect. With. For spinal anesthesia, you use hyperbaric solution. That is 0.5 solution of bupivacaine with dextrose. They can ask this as an MCQ. What percentage of dextrose should be used in water to have a hyperbaric bupivacaine for spinal anesthesia? Remember this, 8.25% of dextrose in 0.5 solution of bupivacaine makes the solution hyperbaric. So that can be used for spinal anesthesia. Maximum you can go till 2 mg per kg. Okay. This bupivacaine, why I have written here adrenaline, no effect with BP. Why? You don't need to combine adrenaline with bupivacaine. With lignocaine, you combine with adrenaline because it increases the duration of action. At the same time, it reduces the toxicity of lignocaine. But bupivacaine, no, there is no effect with adrenaline. So don't need to combine. One of the common side effects with bupivacaine is idioventricular rhythm with QRS broad complex. They might show you an ECG with idioventricular rhythm and a QRS broad complex. And they can cause, which anesthetic can cause this. So this should be bupivacaine. So treatment is B for B. Beryllium is the drug of choice. Ropivacaine, when compared to bupivacaine, has less cardiotoxicity. Now coming to prilocaine. The metabolite is O-tolidine. So it's an oxidizing agent. So it oxidizes hemoglobin to methemoglobin. So it can cause methemoglobinemia. It is more suitable for Beer's block. Okay. Benzocaine, BPL, you remember, IPL, Mari BPL. Benzocaine, prilocaine, lignocaine. Most common maximum effect that causes methemoglobinemia is prilocaine. Even benzocaine and lignocaine can cause methemoglobinemia. Okay. Last one is oxytocin. Is used in the treatment of gastritis. If you see your Gelusil, you can find this anesthetic in that oxytocin. Sometimes even in mucaine gel, there is a product. You can see this oxytocin because it is unionized in acidic pH. So it is also called as mucaine. So it helps in gastritis treatment because it anesthetizes that entire mucosal area. So what happens whenever you eat something, the food particles, even if it touches your peptic ulcer area, you won't have any effect. So more acid secretion is not happening. So at the same time, your gas state is also relieved. So it is unionized in acidic pitch, oxytocin. Okay. Now uses. For surface anesthesia, if it is mucous membrane, that is intact skin, that is non-intact skin, you use lignocaine. Lignocaine for mucous membranes, it is helpful. It can penetrate, it can act. Whereas in intact skin, lignocaine has no action. So you have to use an ointment for broken skin. Okay. Lignocaine is useful only for broken skins, that is mucous membrane or broken skin. If you want to use lignocaine in intact skin, you cannot use it without combining it with 2.5% prilocaine and 2.5% lignocaine, because that can be used in intact skin. So this is called as eutectic mixture. This is called as eutectic mixture. It's nothing but a semi-solid ointment, because the melting point of both the anesthetic is lowered in this combination and they form a semi-solid ointment. So even if the skin is not broken, your ointment can penetrate and can produce anesthetic effect. Whereas if you use lignocaine alone, it cannot penetrate. It can be used only for mucous membranes. Infiltration anesthesia. To block every nerve ending, adrenaline should be added. Okay. Nerve blocks. These are uses of local anesthesia. Whole nerve entering and leaving can be blocked with the help of local anesthesia. Intravenous regional block, which is nothing but Beer's block. So how is this Beer's block performed? So you insert a cannula in the elbow. So it is mainly for the treatment of a block of the forearm or the part below the knee or part below the elbow. So what you do, you insert a cannula, you tie a tourniquet, you give the anesthetic. What happens? Slowly, when you release the tourniquet, the anesthetic effect is produced. That's what's called as intravenous regional block. So drug of choice is prilocaine. Drug of choice is prilocaine. It is least toxic and therapeutic index is very wide. That's why you use for Beer's block prilocaine. But contraindicated in sickle cell disease. Contraindicated in sickle cell disease. No adrenaline is required. No bupivacaine. For regional blocks, do not use adrenaline or bupivacaine because it can potentiate cardiotoxicity. Use prilocaine, drug of choice. Whereas for regional blocks, you can use bupivacaine, anesthetic of choice. But for Beer's block especially, the drug of choice is prilocaine. Okay. Now coming to spinal anesthesia, we all know it is given in L4 and L5 in case of child and L2 in case of L2 and L3 in case of adults. So spinal anesthesia means epidural anesthesia and spinal anesthesia. If you see here, it should given in the epidural space, it is epidural anesthesia. If it is given in the subarachnoid, it is spinal anesthesia. So you have to give it exactly in the spine. Okay. Whereas epidural, it is before the dura. You need not enter it at all. Okay. So see, if you see the layers, first is skin. Second is your subcutaneous layer. Third is your back muscles. Then comes your supraspinous ligament when you put lumbar puncture. Then comes your interspinous ligament. Then ligamentum flavum. Then it starts your epidural space. So epidural anesthesia, you give this epidural space. Then dura mater starts. Okay. So spinal anesthesia, where you give? You penetrate the dura. So you have to give it in the CSF. The anesthesia should reach the CSF. So that's the difference between spinal anesthesia and epidural anesthesia. So CSF leak is more with spinal anesthesia when compared to epidural anesthesia. That's why post-puncture headache is one of the complications of spinal anesthesia. It is less with epidural anesthesia. For spinal anesthesia, you can use lignocaine, 5% in 7.5% dextrose. See, subarachnoid space you give it. Bupivacaine, 0.5% in 8% dextrose. Both you can use. Most commonly, they use lignocaine. Okay. Dose, adrenaline, 7 mg per kg. Without adrenaline, use only 4.5 mg if you are using lignocaine. For intravenous regional anesthesias, you can use 4 mg per kg. But here we usually don't combine this with adrenaline because intravenous anesthesia is not required. So whenever adrenaline is used, high dose is used. Without adrenaline, small dose. That you have to remember. With spinal anesthesia, lignocaine 5% in 7.5% dextrose you can use. Indications: orthopedic surgeries, pelvic surgeries, OG surgeries. Everywhere you can use. Complications: hypotension, treatment with crystalloids, Trendelenburg position, head low, ionotropes. Common adverse effects include bradycardia also. Hypotension, bradycardia, arrest, sometimes respiratory depression. Headache is most common within 12 to 24 hours. It is aggravated by sitting. So patient should lie down after spinal anesthesia for 24 hours. Abdominal compressions can be given to raise the venous pressures, or epidural blood patch can be given. You take patient's blood. Same way how you did spinal anesthesia, you give in the same route, it will go and blood will be entering that, and the patch it will form because of clotting, and the hole will be sealed. So CSF leak won't happen. Common complications include urinary retention. Sixth cranial nerve palsy, most common with spinal anesthesia, that is abducens nerve. Infections, meningitis can happen. Sometimes cauda equina syndrome and paraplegia are also reported. Absolute contraindications for spinal anesthesia: raised ICT, don't give. Patient, it will go more, edema will form. Shock, CSF will flow more. Okay. Shock, don't give. Coagulopathy, don't use, because blood loss will not be stopped when you puncture the dura. Anticoagulant treatment, no, don't use. Infection at site, don't use spinal anesthesia. Absolute septicemia, do not use spinal anesthesia. Relative heart conditions, stenosis, recent MI, or if you have spinal deformity or psychiatric disorders, don't use. There's a relative contraindication. Absolute, raised ICT, shock, coagulopathy and that is thrombolytics, anticoagulants, infection at site, and septicemia. Local anesthesia toxicity management. First, you give 20% intralipid. Then drug of choice for seizures is benzodiazepines. If it is not responsible, if it's not responding, use propofol. Lignocaine can be used if there is arrhythmias because of that, or class 1B arrhythmics can be used. NaHCO, sodium bicarbonate, for lactic acidosis. This is the LA toxicity management. Epidural anesthesia indications: post-operative pain, painless labor. Spinal surgeries, what all can be done under spinal anesthesia, it can be done under epidural anesthesia as well. Upper GI thorax surgeries can be done. Chronic pain in case of cancer patients, pain control, pain management, mainly for post-operative pain, labor pain, and chronic pain. Spinal anesthesia is reliable. It is quick, used for small surgeries with limited time. Post-dural headache, very common. It is difficult because you have to slowly penetrate. But you have to stop exactly before the dura. Spinal anesthesia, no, when you put the needle, when you pierce the dura, you will have a pop. But epidural, no, you have to stop before that pop. So it can be little difficult for an anesthetist. Less reliable. It is slow. For maximum duration surgeries, long duration surgeries also, you can use epidural anesthesia. Decrease post-puncture headache. Concentration LA percentage with respect to 3 types of anesthesia: infiltration, spinal, and epidural. For spinal, you use maximum. For lignocaine, 5. This is all mg, 5 mg. For epidural or LA percentage, you can tell it as percentage also. Okay. So epidural, you use 2 mg. Lignocaine, 0.5 to 2 for infiltration. Almost same. Infiltration, epidural is same. Spinal, little more. Bupivacaine, it is almost same for spinal and epidural. Till 5, you can go for infiltration. Not important, but I'm just telling. Sometimes these people ask these questions as well. So you have to just remember. Okay. Just remember this slide. Infiltration, 0.5 to 2. Lignocaine, bupivacaine, 0.25 to 5. Spinal, 5 mg. Epidural, 2. 0.5 and 0.5. Okay. Concentration of LA percentage. This is all percentage. Mg percentage. So that's it for today's class. I hope I have covered justice for local anesthetic, because this is actually an anesthetic topic. But as a pharmacologist, I do take this regularly, this topic. That's why I wanted to introduce this topic today. So you can have us look at these slides, slowly go through it. Basics of local anesthesia I've told, with all new drugs and everything, and what conditions it can cause, where to use, where not to use, percentages, dosages, indications, comparisons, everything I have covered. So thank you guys. Have a good
Today we'll talk about a very small topic, that is umbilical cord. Just a handful of points to remember with reference to umbilical cord. Fine. So what is the other name for umbilical cord? It is also called funis. Okay. So funis. Now, regarding the umbilical cord attachment, I think all this we have already dealt in the placenta topic itself. But when we talk about the attachment of the umbilical cord, we all know that umbilical cord is attached where? It is attached roughly to the center of the placenta. It is attached roughly to the center of placenta. Center of what surface? Fetal surface. The other end of the umbilical cord is of course attached to the umbilicus of the baby. But if the umbilical cord is attached to say the margin of the placenta, if the umbilical cord is attached to the placental margin, now this is a difference in attachment. Okay, now this is called battledore placenta. Now this is battledore placenta. Okay, now the third picture that we see here is a deviation from all this. Now this picture is showing a very different attachment, which we'll be talking as a exclusively a different topic. See, this is cord getting attached to a membrane. Now this is the umbilical cord. This is a membrane to which the umbilical cord is attached, and that membrane is attached to the placenta. Okay, now we note that this membrane is highly vascular. Now this membrane is highly vascular. Okay, now this sort of attachment of the umbilical cord to a membrane and then that membrane getting attached to the placenta. Now this sort of attachment is called velamentous insertion of cord. This is velamentous insertion of umbilical cord. Yes. Is it a problem always? Yes, of course, it's a problem. Not always, but when this membrane, now, is it a problem? Yes, it's a problem when if this membrane becomes the presenting part. I'll write PP. Fine. If this membrane becomes the presenting part, then it can be a problem. Now, I'll draw a picture of that. What is the meaning of presenting part? The part of the fetus which presents at the lowermost point and which is visible on or which is palpable by pervaginal examination. Now that is presenting part. This is uterus, the placenta, and this is the umbilical cord which should be attached to the placenta, but it is attached via membrane. Now say this is the membrane. Is that okay? Now this velamentous membrane, you can see if this membrane becomes the presenting part, so inside we have the fetus, okay, and the like. If this membrane becomes the presenting part, now this is called vasa previa. Vasa previa is an extremely rare phenomenon. It's not very common, but when it occurs, it's very dangerous because a rupture of the blood vessels in the membrane. Now we see that this membrane is highly vascular. Okay, so this is the presenting part. So when you do your ARM, now what is beneath that amniotic membrane is actually here. It is the this membrane of the velamentous insertion of cord. So what will happen is this blood vessels, fetal blood vessels, are liable to get ruptured. Inevitably, they will be torn if a normal labor is allowed, which will lead to massive blood loss from the fetus, and which is called fetal exsanguination in fetal, not just blood loss. We give a better terminology for that. Fetal exsanguination. I mean, it's like literally letting off all the blood of the fetus. So fetus drains very fast. Okay, so fetus exsanguination in labor. So this is a cause, another cause for antepartum hemorrhage. But then here, this antepartum hemorrhage is fetal bleeding. We had already learned the definition of antepartum hemorrhage in our previous classes. So antepartum hemorrhage is bleeding from the female genital tract anytime after 28 weeks and before the birth of the baby. So we know the definition for antepartum hemorrhage. And also the causes of antepartum hemorrhage, the two most important causes are abruptio placenta and placenta previa. Now, this antepartum hemorrhage, after we have learned about vasa previa, now this can be classified as if this antepartum hemorrhage is from is it from maternal bleeding or fetal bleeding? Is that okay? Now, antepartum hemorrhage, bleeding, maternal bleeding means bleeding from the placenta is of course maternal bleeding. So, maternal bleeding, we have abruptio placenta and placenta previa. Abruption, I'll simply write abruption, placenta previa. Not only this, but also a lot of other local causes. Say local causes like erosion cervix, or it would be a cervical polyp, a vaginal erosion, a cervical cancer, of course, sometimes coexisting in pregnancy, or a vaginal cancer, which is coexisting. So from local lesions. If it's fetal bleeding, then it is vasa previa. Right? So I hope you are all able to understand this. Okay. So this is how we actually classify. So vasa previa and what? Fetal bleeding and maternal bleeding. Is that okay? Fine. So this is basically a problem with what? The insertion of the umbilical cord. Okay. Now we'll talk about cord knots. So what you see in two pictures. Now this is true knot of the umbilical cord, and this is false knot. Is that okay? Now this is false knot. One is true knot and the other is false knot. Now true knot is definitely like a knot of any twine or any thread or rope like that. So it's like this. True knot is formed because of fetal movements. Fetal movements. The knots can be loose or the knots can be tight. And tight knots are of course dangerous. Knot forming between two babies in twins. Knotting. Now this concept is very, very common when both the babies are in the same amniotic cavity. Monoamniotic twins. So in monoamniotic twins, we have more formation of knots. So this is most important complication of monoamniotic twins is cord entanglement. Okay. So that is extremely common in monoamniotic twins. What you see in the second picture is a false knot. Now, false knot is basically only local aggregation of Wharton's jelly. Local aggregation of Wharton's jelly. You know that surrounding the umbilical vessels of the umbilical cord, some jelly-like substance is present, and this is to prevent compression of the blood vessels, and that is Wharton's jelly. Okay, and this is a scan ultrasound picture of a normal umbilical cord. So normal umbilical cord, you should exactly see this. This is the cut section, how it will appear. You should see this Mickey Mouse appearance. So you're seeing this. See this umbilical cord also, you can note. This is because cord, you will see cross sections at many places. This is Mickey Mouse sign. Okay, and what you should see, you should be able to see two umbilical arteries and one umbilical vein. So that is what you're seeing, two umbilical artery and one umbilical vein. This is after the Doppler identification. Now we are again seeing what two umbilical arteries and one umbilical vein. Okay, but sometimes if two umbilical arteries. So remember, normally two umbilical arteries and one umbilical vein. Okay, and we all know initially what two arteries and two veins are there. Yes or no? Initially two umbilical arteries plus two umbilical vein. But so this is around 16 weeks of gestation. Now this is also a very important question in the exam. The right umbilical vein disappears and the left umbilical vein is left. So that is very easy to remember. Left is left. Okay. So left umbilical vein is left. So we have two umbilical arteries and one umbilical vein. Okay. Now we have a specific entity here called single umbilical artery. See, now you can see in the picture, we should have two umbilical arteries, but we are having only single umbilical artery, SUA. Is it very significant or is it insignificant? That is the point here. Single umbilical artery is present in 1% of singleton, and it is 5 times more common in twins. So incidence in singleton is 1%, incidence in twins is 5%. Okay, and 1/4. So out of 4 cases of SUA, single umbilical artery, 1 case will be associated with congenital anomaly. So it's not that all cases of single umbilical artery are associated with congenital anomaly, but then still you have to be very cautious. And the anomalies most common are renal genital anomalies, and the trisomy that is associated with single umbilical artery is trisomy 18. Okay, there is increased incidence in perinatal mortality, increased incidence in preterm labor, IUGR, all that. Okay, so that is all about single umbilical artery. So to the questions, now 4 vessel cord becomes a 3 vessel cord by, we know the answer, it is 16 weeks. Now this is usually asked. The consequence of the placental abnormality shown in the picture is, we all know it is antepartum hemorrhage and it is fetal bleeding. Folds of Hoboken are present in the umbilical cord and that too in the umbilical arteries. So please remember all these terminologies because they can come as one-liner questions in the exam. Now, decidual space is obliterated. I had dealt about this obliteration of decidual space in previous classes by 16 weeks. I have placed 2 questions here side by side because I want you to remember this. So at 16 weeks, what are the important milestones to remember? One is decidual space obliteration. One is decidual space obliteration. The other is I told you 4 vessel cord, appearance of the left umbilical vein is left. So you can write that left vein is left. Okay, and the quickening is felt by a multi around the 16 weeks. Quickening felt by multi around the 16 weeks. So all these are important events that are happening. So which of the following statements in relation to single umbilical artery is true? It is more common in singleton is false. It's always associated, never, 1 out of 4. Most common trisomy is trisomy 18, that is right. Presence of single umbilical artery is definitely not insignificant. There is a high association of congenital anomalies. I mean 20 to 25% association. So we really have to be careful about it. And some 1 or 2 points about the length of the umbilical cord. Usually it is said length of the umbilical cord is equal to length of the baby, but still we can give a range. It's between 30 to 100 centimeter. Okay, so when the cord is less than 30 centimeters, we call it a short cord. When umbilical cord is more than 100 centimeters, we call it long cord. Is that okay? So you need to remember both short cord definition and long cord definition. Is that okay? Fine. So thank you all today for your patient listening. It's such a small topic. I'll meet you tomorrow on another topic.
Hello everyone, this is Dr. Sneha, and today we'll be discussing a few MCQs briefly from the topic of female infertility. Let's look at an MCQ. A 25-year-old woman is being evaluated for infertility for the past 2 years. Her cycles are irregular, 3 to 4 days occurring for every 60 to 70 days since the last 3 years. Which of the following tests is not useful to confirm if she is ovulating or not? So your task is to find out which are all the tests that is useful to detect if she is ovulating or not, or if she is releasing egg every month. Okay. So your options are mid-luteal phase progesterone, basal body temperature, urinary LH measurement, or endometrial thickness measurement by transvaginal ultrasound. Okay, so the answer here is endometrial thickness by TBS. This is not a test that is used to find out if the patient is ovulating or not. Okay, a thick endometrium around the time of implantation, that is few days or during the ovulation of at least 8 millimeter, is a good sign that the endometrium is ready to receive the zygote if at all it is formed. But it does not mean that the woman has ovulated. Whereas all of these three options are valid methods to detect if the patient has produced an egg that cycle or not. So let's look at some of the ovulation tests that are available. The first and the easiest of all is to look at her history. Usually, if a woman is ovulating, she'll have regular cycles. Okay, regular cycles, and she might have spotting around the day of ovulation, that is around day 14, if the patient has regular cycles, and she might even have pain mid-cycle. When the ovum is reduced, we call this Mittelschmerz pain. Okay, so look for these points in the history. The second is measurement of mid-luteal progesterone by taking a blood sample. We know that when the woman ovulates, the secretory phase of the cycle starts and progesterone is produced by the ovary. So, presence of progesterone in the second half of the cycle in the luteal phase is a confirmatory test to see if the patient has produced egg or not. If the patient has not ovulated, there will still continue to be increased estrogen level, but there will be no progesterone. Okay, and the ideal time to do this is mid-luteal. Luteal phase of the cycle in somebody with regular cycles is between the 14 to 28 days. That is the second half of the cycle. So middle of this will be around the 21st day. Okay. This is in a regular cycle woman, you do the test around the 21st day, and if the progesterone level is more than 3 nanogram per ml, it means that the patient has ovulated. But what about in somebody with irregular cycles? How do we define mid-luteal part of the cycle? So you take which is her longest period of cycle. For example, let's take that her longest cycle lasts for 35 days. She gets a period every 35 days. So you do this mid-luteal progesterone 1 week before her expected periods. Okay, so if it is 35th day, you do the test around the 28th day, the progesterone test. All right. Next is basal body temperature. This is the easiest and the cheapest method, but it is not very reliable and it is very cumbersome. You need to do the test every day to find out if you have ovulated. So because of the production of progesterone after ovulation, what progesterone does is that it increases the body temperature very slightly by around 0.5 Fahrenheit. Okay. So you have to measure your temperature first thing in the morning before getting out of the bed, before doing any other activity, and you need to plot it on a chart. Okay, and once you have ovulated, there will be a slight increase in the temperature, around 0.5 Fahrenheit increase in the temperature. So this pattern is called as biphasic pattern when you plot it, because there is one phase here, another temperature phase here. Okay. Next method is to check for luteinizing hormone presence in the urine or in the blood. Okay. We know that around 36 hours before ovulation, LH has to surge. LH surge is one of the most important positive feedback mechanism before ovulation, if we can recall from physiology. So this is what you're trying to detect. So around 2 to 3 days, 1 to 2 days before your expected ovulation time, you need to check for presence of LH either by simple kits that are available in the pharmacy by urine, or you can measure your LH in a lab. If you're measuring through serum level, LH more than 40 international units per ml is suggestive of an LH surge. Okay. Another method and another very effective method is to monitor for the growth of the follicle throughout the cycle. This is usually started from around day 9 to day 10 of the cycle, when you expect dominant follicle to be visualized. Okay, and this dominant follicle will slowly increase in size. Close to ovulation, Graafian follicle will be formed, and a proper Graafian follicle will be around 18 to 20 millimeter. Now this growth of the follicle can be measured and visualized by transvaginal ultrasound. But you should not stop with this. Once ovulation has occurred, the egg will be released and this Graafian follicle will collapse. Okay, so you need to document this collapse also if you want to confirm ovulation. The last method is by doing an endometrial biopsy, but this is not routinely done. Okay, usually this is done on the 24th to 26th day of the cycle. Again, what you're seeing is if there are any changes in the endometrium because of progesterone, whether there are any secretory changes in the endometrium. Okay, but the main disadvantage with this is that suppose if the patient has ovulated and it has implanted in the uterus, you are artificially or iatrogenically curating out or doing something very similar to a DNC. So usually this is not the first method or the investigation of choice. Okay, from theoretical point of view, this can be used. All right. The other advantage with endometrial biopsy is that you can also diagnose genital tuberculosis and diagnose luteal phase defect. All right. Let's look at another MCQ. A 30-year-old woman has visited her infertility evaluation. She has history of being treated incompletely for a sexually transmitted disease, that is chlamydia, around 1 year back. Her cycles are regular, around 3 days every 30 days, with no other complaints or comorbidities. What would be the most appropriate test to detect the most probable cause for her infertility? So first you should know where the fault lies, why she is having infertility, and then you should see which is the best test that is helpful to detect that. So here we see that the cycles are regular. So we can assume that she is ovulating for all practical purposes. Okay. The key point here is that she was incompletely treated for chlamydia a year back. Chlamydial infection or any pelvic infection is a very big risk factor for tubal damage. Okay, tubal damage, because chlamydia and gonorrhea and such infection can cause damage to the cilia and the tube. So it will affect the transport of the ovum from the ovary to the slowly to the uterus. So your doubt is probably it is a tubal damage from the history. Okay, so which is the test that is used to detect tubal damage? Is your option HSG, hysterosalpingogram, transvaginal ultrasound, midluteal progesterone, or postcoital test? We saw from the previous slide that mid-luteal progesterone is a test used to detect if the patient is ovulating or not. Here, you're suspecting tubal damage or not ovulation, so this is not the option. Postcoital test is a test where you collect the secretion from the posterior fornix immediately after the women have had intercourse to see if there are any antibodies that is destroying this sperm. Okay, mainly it is to detect any cervical factor. All right, so this is also not an option. Transvaginal ultrasound is a very broad investigation that is used for multiple purposes, and just a blank TVS cannot be used. Tubes are not structures that are usually visualized by transvaginal ultrasound because tubes are usually collapsed on each other. You can see the uterus, you can see the ovaries, but tubes are not something that you visualize by doing a plain transvaginal ultrasound. So again, this is not the option. Your correct answer is a test called hysterosalpingogram. Let's briefly look at some of the buzzwords that you have to look in the question when you suspect tubal causes for infertility. What are the risk factors? Not every woman is prone to have a infertility due to tubal cause. Tubes are damaged because of certain factors. And what are some of the factors that can damage the tube? First, as we already discussed, is pelvic inflammations, especially PIDs such as chlamydia, gonorrhea, and tuberculosis, genital tuberculosis. These can damage the cilia in the tube, okay, and they can cause tubal blockage as well because of inflammation. The second cause is if the patient has had a previous tubal ectopic pregnancy, and whatever may be the mode she was managed, either medical or surgical, it can cause a little bit of damage to the tube, okay, and this can also cause tubal causes of infertility. Third is endometriosis. Endometriosis can cause peritubal inflammation and adhesions. Peritubal means around the tube. All right, it is not something that causes damage inside the tube, but it is something that causes damage on the outer side of the tube. Peritubal inflammation adhesion, and it can cause tubal block if it is very severe. All right, so you look for features of endometriosis in the clinical scenarios such as severe dysmenorrhea or dyspareunia. All right, these are some of the buzzwords to look for. And the fourth risk factor is if she's had any pelvic surgery, especially if she's had any previous tubal surgery, for example, to treat an ectopic, or if she's had a tubal sterilization, a very obvious cause which will cause mechanical obstruction. Sometimes surgery to other pelvic organs very close to the tubes, for example, appendix or lower intestinal tract surgery, can also cause inflammation and adhesion around the tube, and it can indirectly cause tubal blockage. All right, so look for these certain clues you can look in the clinical scenario to see or to suspect if the infertility is because of the tubal cause. Now let's look at some of the tests to see if the tubes are functioning well or not. For the tubes to be responsible to cause a proper pregnancy, you need the tubes to be patent. That means it needs to be open and the cilia needs to be functioning well. Basically, there should be no blockage right from the fimbria up to the uterine entry or to the cornea. So you're trying to establish that this pathway is clear, okay? And as I already told you, by transvaginal ultrasound, a normal tube cannot be visualized. So you need to insert some object or some solution inside which can be visualized by various imaging methods so that you can confirm whether the tube is patent or not. The first method or the initial investigation of choice would be hysterosalpingogram, and it is a type of X-ray of the pelvis. You insert a contrast medium Okay, you insert a cannula into the cervix and you inject a contrast medium through the cannula. And if you can see, this is the uterus, and you can see the contrast that is traveling through the tubes and spilling into the peritoneum. All right. So if you can see the entire outline of the tube and the dye spilling into the peritoneum, it means that the tubes are patent. Sometimes all you can see is this triangular structure, which is the uterus, and you will not be able to see this part. That means the dye has not traveled into the tubes and the tubes are blocked. The main disadvantage is that this can be used only as an initial investigation, and sometimes it can have a false positive result, which means that the tubes are actually patent, but by doing the test, you can't see the dye that is flowing along the tubes. This can be because of certain factors such as corneal spasm. That means the cornea are contracting because of pain and not letting the dye go inside the tube. It can be because of some dirt or debris that is mechanically covering the cornea. So if you detect that the patient is having tubal blockage through HST, you need a diagnostic test after this to confirm the finding, and I'll come to what the diagnostic test is. The second method is something called as hysterosalpingo contrast sonography, otherwise called as HIPO-C. Now, if you do the same procedure as HSG by using a transvaginal ultrasound, it is called as hysterosalpingo contrast sonography. By using a transvaginal ultrasound, you insert a cannula or a Foley's catheter inside the cervix and inject a dye. Now, can you see that this white bright area, this is the uterus, okay, and you're viewing a sagittal view, and this is the cavity of the uterus, and you can see that the dyes are spilling over to the tubes on either side. This is the uterine cavity. All right, the bright thing is the contrast. So the same principle, but in HSG you use the X-ray, in HIPO-C you use the transvaginal ultrasound. The third is a simple procedure called as saline infusion sonography. Again, here you use transvaginal ultrasound, but instead of a contrast material, you use normal saline. Okay, so this is how it looks like. This is the uterus, sagittal view of the uterus, and you inject normal saline through the cervix, and you can see the endometrial cavity distending with normal saline. Okay, how you detect if the tubes are patent or not? Usually, if the tubes are patent, this normal saline will travel through the tubes, through the fimbria, and it will spill into the POD. And usually, this is the POD. This is the anterior part of the woman. This is the posterior part. Okay. So here, if you see a black structure like this behind the uterus also, that means the fluid has spilled into the POD. That means the tubes are patent. This is a relatively simple test, and the disadvantage is that you cannot know if both the tubes are patent. If the fluid is present in the POD, it means that it has spilled through one of the tubes, but you do not know if both the tubes are patent. If all of the tubes are obstructed, you can't find out which tube is obstructed. Again, you need a diagnostic test to confirm the finding. So that brings us to the diagnostic test. Okay, laparoscopy by doing chromoperturbation is the diagnostic test or the gold standard test to diagnose and to confirm tubal patency. The test is called chromoperturbation test. Okay, this is the same principle. By laparoscopy, you visualize the uterus. Now you're looking at the back of the uterus. This is the posterior surface of the uterus. This is the ovaries on both sides, and this is the tube and the fimbria. Okay, if you can see a bluish dye here. There's a bluish tinge, and that has spilled over and got collected in the POD here. Okay, this is the best method because you can visualize the dye actually entering the tube because it turns slightly bluish, and you can see the dye spilling from both the tubes if at all the tubes are patent. Okay, so the laparoscopy by chromoperturbation test is the diagnostic or the gold standard test, and these are the tests that are available to test the tubal patency. That brings us to the end of today's brief discussion about tests of ovulation and tests of tubal infertility, tubal patency from the topic of female infertility. We'll see again tomorrow with another important topic. Thank you.
Good evening, students. Today we'll be continuing our discussion on skeletal muscle. So I'll just summarize what we've studied in our previous class in the initial. So as we've studied, a myofibril, which is the basic structural unit of a muscle, is composed of various actin and myosin filaments. So in each myofibril, there are 3,000 actin molecules and around 1,500 myosin molecules. Each actin filament has a diameter of 1 micrometer, and each myosin filament has a diameter of 1.6 micrometers. Multiple myofibrils along with the sarcoplasm will form the muscle fiber. The muscle fiber, the individual muscle fiber, is covered by a connective tissue sheath called as endomysium. Multiple muscle fibers together forming the muscle fasciculus. The muscle fasciculus covered by a connective tissue sheath called as the perimysium. Multiple muscle fasciculus together forming the muscle belly. And the muscle belly is surrounded by a connective tissue sheath called as the epimysium. Now, the region where muscle connects to the tendon, all these three layers will fuse together and will connect to the tendon sheaths, and ultimately the tendon will insert into the bone. Now, it is because of this actin as well as myosin filaments present in the myofibrils that the basic, striated appearance of the skeletal muscle is present because of the interdigitations that are present, plus because of the peculiar arrangement of this actin and myosin molecules, the muscle is striated in appearance. We have also discussed the structure of a sarcomere. So a sarcomere basically involves half of I band plus the entire A band plus half of I band. So 2 half I bands and A band forms a sarcomere. A sarcomere, again, in the middle, this is the myosin filament and actin filaments on either side, stretching or extending towards the midline, connected on the periphery via the Z discs. So the distance between the two Z discs is called as a sarcomere. We have also discussed the structure of a myosin molecule as well as a myosin filament as well as that of actin. So we know that myosin filament is made up of multiple myosin molecules. Almost 200 myosin molecules form one myosin filament. The arrangement is such that half of the myosin molecules extend in one direction, the other half extend in the opposite direction, because of which the cross bridge of the myosin molecule extends in all directions away from the midline. So in the center portion, there are no myosin, there is only the tail portion of the myosin molecule. No cross bridges are present, but on either side, the cross bridges are staggered in all directions. Again, the cross bridge, it is flexible at two edges. So where the myosin, multiple myosin filaments, the tails uniting together to form the body of the myosin filament. So an arm protrudes plus the head protrudes away from the arm. So the myosin molecule can hinge at two different places. One where the arm leaves the body of the myosin filament, and the second where the head leaves the arm of the myosin filament. Talking about the actin, so the backbone is formed by 2 F-actin strands, and each of the F-actin strand is further formed by multiple polymers of G-actin. So multiple G-actin will form F-actin, and then 2 strands of F-actin will form the backbone of the actin molecule. And each of the G-actin molecule has a site, or let's say is attached with an ADP molecule. So this is the actual active site on the actin filament where the myosin cross bridges will come and unite with the actin molecule. There are 2 regulatory proteins, the troponin complex and the tropomyosin complex. So normally tropomyosin, it lies in the grooves in between the F-actin molecule and hence covers all the active sites of the actin filament in the resting state. Troponin complex, it is a 3-protein subunit, troponin I, C, and troponin T. And accordingly, it has different affinities for different molecules. Talking about the general mechanism of muscle contraction, so whenever an action potential travels from a nerve, it is going to release acetylcholine at its nerve endings. This acetylcholine will now act on the acetylcholine gated sodium channels, which will lead to opening up of these channels and lead to influx of sodium inside the muscle membrane. Now, this will lead to a change in membrane potential and will lead to further activation of voltage gated sodium channels. And once voltage gated sodium channel opens, there is a large influx of sodium ions inside the muscle fiber membrane, leading to generation of an action potential. Now, the action potential in a muscle membrane will spread in the same way like an action potential spreads along a nerve membrane. So the action potential will spread along the entire skeletal muscle membrane as well as inside into the middle of the muscle fiber membrane through the sacrotubular system, which we'll subsequently discuss. Just for now, remember this. So it enters the middle of the muscle fiber membrane through the sacrotubular system. Once the muscle action potential enters the muscle membrane, it leads to release of large amount of calcium ions from the intracellular sarcoplasmic reticulum, which are modified endoplasmic reticulum present in the skeletal muscles. And it is ultimately these calcium ions which are responsible for generation or which are responsible for activation of the actual muscle contractile mechanism. So now let's see how this calcium brings about its role. So now this calcium ion, basically the troponin molecule that we have discussed, one of the subunit, that is troponin C, has a very strong affinity for calcium ion. So here what we can see is this is the structure of a sarcomere, first in the relaxed state and the second one is in the contracted state. So as you can see in the relaxed state, the actin filaments are just beginning to touch each other, and they are not much overlapping each other. Even the Z discs are far away. But as you can see in the lower diagram, the actin filaments have almost completely overlapped each other. And even the Z discs have begun to be pulled inside, leading to reduction in the size of the sarcomere and bringing about muscle contraction. So now what exactly is bringing about this muscle contraction? The entire mechanism was described as the sliding filament mechanism. It is also known as the ratchet theory, based on the scientist Huxley, who invented or who discovered or who basically gave the idea of this sliding filament mechanism. So what exactly is bringing about this sliding filament mechanism? So this basically indicates the interaction between the actin as well as the myosin cross bridges. So basically the myosin cross bridges and the actin filaments interacting with each other, which basically leads to sliding of the actin filament over the myosin molecule. So this brings about the muscle contraction, or let's say the shortening of the sarcomere, which is a mechanical event in response to action potential, which was an electrical event. So now let's see what are the different phases of this sliding filament mechanism. So now, initially, as we have seen in the resting state, the actin filaments, the active sites on the actin filament are completely blocked because of the placement of tropomyosin molecule in the groove between the actin filaments. Plus, troponin is also present, but now again, it is in an inactive state. Now, whenever an action potential spreads, it leads to release of large amount of calcium ions from the intracellular stores. And this calcium ion now interacts with troponin C. The interaction of calcium with troponin C brings about a conformational change in the entire structure of the actin molecule, leading to lateral shifting of the tropomyosin molecule. And now the active sites on the actin filament are exposed. When it is in an inactive state, all the active sites will now be covered by the tropomyosin molecule, and the myosin cross bridges would now be unable to attach. But once calcium troponin complex activates this entire actin filament. The tropomyosin slides laterally, uncovering the active sites on the actin molecule. So now first site was uncovering of active sites. Now coming to the second stage. So now what happens is, once now the active sites have uncovered, so the next step should be the binding of the myosin cross bridge to this actin molecule. So myosin, as we have discussed in our previous session, the myosin head has ATPase activity. That means it has the ability to cleave ATP. So now the myosin head, it binds to an ATP molecule, and because it has an inherent ATPase activity, it will cleave this ATP molecule into ADP and one molecule of phosphate. So ATP will now be cleaved to ADP plus a molecule of phosphate. Now, till the time the myosin has not attached to the actin, it is now actively breaking down ATP into ADP and phosphate, and these breakdown products are still attached to the myosin head. This leads to a perpendicular arrangement of the myosin head, and now the myosin head along with the ADP and the phosphate will go and attach to the actin active site. So this is attachment of the myosin cross bridge to the active sites on the actin molecule. Now, once this attachment happens, the energy that is stored in the myosin head will now be released, leading to a conformational change in the head of the myosin. So now the head, instead of a perpendicular position, will now take a power stroke. That means from its 90-degree position, it will now flex to a 45 degrees position. So this portion is called as the power stroke. That is, the head from a 90-degree perpendicular position will now become 45 degrees. And the energy that was stored in the form of ADP and phosphate will be utilized for this power stroke, and the ADP will now be released. With this, the power stroke happens. So as we can see, as the power stroke has happened, the actin filament has come closer to each other. That is, the actin molecule has now slided over the myosin head. Now, once the myosin has had its power stroke, once it has come to a low energy configuration, that is the 45-degree configuration, and the ADP molecule is now detached, the myosin head is again active. It is again going to be able to get attached to one molecule of ATP. So now to this head, again an ATP molecule will attach. The attachment of ATP molecule to the myosin head. So the myosin ATP complex has a very low affinity for the actin molecule, because of which the myosin head will now detach from the ATP molecule, and now the energy will again be stored because the ATPase activity will again be activated, and this ATP molecule will now again be cleaved into ADP and phosphate. So this cycle will continue until multiple power strokes has happened. So with each action potential, this activity, this entire cycle will repeat itself. So first, the calcium ions will, expose the active sites on the actin, leading to attachment of the myosin head to the active sites, which has now already cleaved an ATP molecule. Now, once it is attached, the ADP and the phosphate that was stored will now be utilized. So the energy will be utilized for the power stroke, and hence now the actin will go on sliding over the myosin head, and the muscle will go into a phase of contraction. So this entire mechanism is called as the sliding filament theory, based on the sliding nature of actin over myosin heads. So always remember this, that It is the sliding filament theory because the actin is sliding over the myosin head. First, ATP is binding, ADP and phosphate becoming still attached. The perpendicular configuration will now attach to the active site on the actin, which will lead to release of this particular energy, and the power stroke will happen in the myosin head, where it will change from its perpendicular configuration to and low angle configuration. That is, from 90 degrees, it will come to 45 degrees. And this action is called as the power stroke. Now again, the myosin head can attach another molecule of ATP. And because ATP and myosin head has lesser affinity to the active site on the actin molecule, it will detach and it will become ready for the next cycle of molecular contractility. With this, we come to an end of discussion of today's topic. Thank you.
Good evening, everyone. So we are continuing with the discussion on amino acids, and today we will be discussing about serotonin and melatonin. Now, serotonin and melatonin are derived from a amino acid tryptophan, which we had studied few days back. Let's quickly revise few things about tryptophan. Tryptophan is an aromatic amino acid. It is a heterocyclic amino acid. It has a indole ring. It is neutral amino acid. It is essential, polar, and it is both glucogenic and ketogenic. Now, we get few important substances from tryptophan, which is alanine, acetyl-CoA, formyl group, niacin, serotonin, melatonin, indole acetic acid, and indica. These are the important substances which we get from tryptophan. Today, we will restrict our discussion to serotonin and melatonin. So let's start with serotonin and melatonin synthesis. Now, what is serotonin? Serotonin is otherwise called as 5-hydroxytryptamine, 5-HT. Okay, it's a neurotransmitter synthesized from tryptophan, and about 1% of the tryptophan is converted to serotonin. The production of 5-HT occurs in the target tissues where it is required. Okay, so which are these target tissues? The target tissues are brain, mast cells, platelets, gastrointestinal tract, mucosa, and intestinal cells. The first step, okay, if the tryptophan is first hydroxylated to 5-hydroxytryptophan, and here the enzyme is tryptophan hydroxylase, and we require tetrahydrobiopterin as a cofactor. Tetrahydrobiopterin is required as a cofactor. The next step is the 5-hydroxytryptophan getting decarboxylated by a pyridoxal phosphate dependent decarboxylase. Okay, pyridoxal dependent decarboxylase to give 5-hydroxytryptamine, or otherwise called as serotonin. Okay, now remember this, platelet contains the high concentration of serotonin. Platelets contain a high concentration of serotonin. How is this 5-hydroxytryptamine or serotonin going to get degraded? Monoamine oxidase, MAO, degrades the serotonin, which is excreted into 5-hydroxyindole acetic acid, 5-HIAA. Okay, this is excreted in the urine, and small portions of serotonin is conjugated with sulfate or with glucuronic acid and excreted through urine. Now let us discuss about the functions of serotonin. Now, the most important thing is it's a neurotransmitter which is involved in the regulation of the cerebral activity, especially excitation. It is an excitatory neurotransmitter. It's a powerful vasoconstriction and results in smooth muscle contraction in the bronchioles and arterioles. It controls the behavioral pattern, sleep, mood, appetite, blood pressure, and body temperature. And it is highly necessary for the motility of GIT. And in platelets, we just now learned that there is a high concentration of serotonin in platelets. It is required for platelet aggregation. Its deficiency causes depression. Okay, so what it means is that serotonin actually acts as an antidepressant. Okay, and the levels are decreased in the depressive psychosis. A carbohydrate rich meal induces sleep. A protein rich meal causes alertness. The explanation to this is, in a protein rich meal, what happens is there's a traffic jam of different amino acids, and tryptophan, being the bulkiest amino acid, is taken up very slowly. In the carbohydrate rich meal, there is increased insulin release and decreases the amino acid in blood. So tryptophan easily enters into the brain and it induces sleep. Okay, this is the reason why carbohydrate rich meal induces sleep, whereas a protein rich meal causes alertness. Okay, so it will be a good idea when we attend classes to have a protein rich meal rather than a carbohydrate rich meal. Now, effects of drugs on serotonin. Okay, I'll just touch upon it, will not go into too much of details. Okay, now ipronosib, it inhibits the MAO and elevates the serotonin levels, so it's a psychic stimulant. Then we have reserpine, it increases the degradation of serotonin, so it's a depressant drug. Then we have the very famous LSD, that is lysergic acid diethylamide, which competes with serotonin, so it is also a depressant. Then we have the SSRIs, that is selective serotonin reuptake inhibitors, the common name being sertraline. It increases the serotonin in brain and synaptic site, and it acts as an antidepressant. So coming to the clinical application of this carcinoid syndrome. Now, it is otherwise called as argentinophenomas, which are tumors of the argentaphin cells of the gastrointestinal tract, mainly intestine and appendix. Now, there is an uncontrolled growth of these cells, and hence there is an increased levels of serotonin. And the clinical features are flushing, sweating, intermittent diarrhea, and fluctuating hypertension. Carcinoid tumor or malignant carcinoid syndrome. Now, in carcinoid syndrome, very high amount, that is up to 60% of tryptophan is diverted for the serotonin production. We learned that in a normal situation, only 1% is diverted. Here now 60% is getting diverted, which impairs the synthesis of NAD, and there will be a niacin deficiency, and hence the clinical features of pellagra will be seen, that is dermatitis, diarrhea, dementia, and if not treated, leading to death, the 4 Ds of pellagra. How we diagnose it? The excretion of 5-hydroxyindole acetic acid, 5-HIAA, in urine is tremendously elevated. It becomes up to 500 milligrams per day against a normal of less than 5 milligrams per day in carcinoid tumor of the gut bronchus, oatfill carcinoma of lungs. Now, the estimation of 5-HIAA in urine is used for the diagnosis of this disorder. Now, let us discuss about melatonin. Melatonin is a hormone which is synthesized by the pineal gland, and it produced from the serotonin produced from the tryptophan is acted upon by serotonin and acetylase to give N-acetyl serotonin. Now, serotonin and acetylase is the rate limiting enzyme for this particular reaction. N-acetyl serotonin undergoes methylation to with the help of SAM, that is S-adenosylmethionine, being the methyl donor, to produce melatonin. The synthesis and secretion of melatonin from pineal gland is controlled by light. What are the functions of melatonin? Melatonin is involved in the circadian rhythm or the diurnal variation, that is 24-hour cyclic process of the body, and it plays an important role in the sleep and wake process. Melatonin inhibits the production of melanocyte stimulating hormone, MSH, and adrenocorticotropic hormone, ACTH. And melatonin also performs a neurotransmitter function. Now, the clinical application of this is Hartnupp's disease. Now, it is an hereditary disorder, autosomal recessive in nature, due to an impairment in the absorption and or transport of tryptophan and other neutral amino acids from the intestine, renal tubules, and brain. This leads to the deficiency of niacin and serotonin, and the symptoms include pellagra-like symptoms, that is including dermatitis, ataxia, and mental retardation. Now, the diagnosis, how do you diagnose it? Low plasma levels of tryptophan and other neutral amino acid and their elevated urinary excretion, that is, there will be amino acid urea. Then there is increased urinary output of indole acetic acid and indole pyruvic acid, which are detected by Obermeyer test. Which are detected by Obermeyer test, which is an important question. Okay, the major excretory product of tryptophan comes in urine. How do we treat this condition now? For treating this condition, we give the patient a high protein diet with supplementation of niacin and week of minimum exposure to sunlight. Let's try answering few questions. Argentine phenomas are usually seen in GIT, heart, lungs, brain. So you are absolutely correct. It is seen in the most commonly seen in GI tract. Let's try to answer one more question. Argentine phenomena are carcinoid syndromes. Okay. So let's answer one more question. Now, Hartnupp's disease is associated with the defective absorption of the following amino acid. Option A, tryptophan. Option B, proline. Option C, arginine. Option D, lysine. Yes, you're absolutely correct. The correct answer here is tryptophan. Okay. So with that, we conclude our discussion on serotonin and melatonin. We will continue with the discussion on amino acids tomorrow. Till then, have a good time. That's my time for today. Thank you for patient listening.
Good evening, friends. On behalf of Radiology Today, I will be continuing on the discussion which we are continuing, that is the renal system radiology. So, yesterday we saw a question, that is a patient presents to the casualty with abdominal pain and sterile pyuria, which can also be called aseptic pyuria or antiseptic pyuria. The four options were A, puticini, B, nephrocalcinosis, C, calcified soya sepsis, and D, Staghorn calculi, right? So what is my topic of discussion today is, I will be going to show you images, that is radiology images of all these options, so that even if they give you the image, you will be able to crack it, okay? So first I will take you with the image of that is puticini. Friends, first of all, when they are giving you an image of puticini, okay, so how to decode the images? Remember, as yesterday I told you, whenever they give you a zoomed in image, that is a specific part of the image is given. For example, this image is an image of abdominal X-ray. Okay, the abdominal X-ray starts from both the diaphragm taken up to the level of the pelvis fronts. But what they have done here is, in that they have specifically they have cut a part of the abdominal X-ray. In this case, it is they are showing you the kidney part. Okay. So, how to tell that it is puticini is, first of all, puticini can be either it can be unilateral or bilateral. Okay, and when you look at this is the kidney, friends, the entire kidney. What has happened here? The entire kidney, the cortex part and the medulla part has gone for calcification. Only the pelvic calyceal system is left here. Okay, so this is an example of puticini. Also, if you appreciate here, you will be able to see the ureter, friends. This is the ureter part and it is appearing calcified here. If I erase, you will be able to appreciate right now. You will be able to see a linear calcification, right, that is present along the walls of the ureter. Okay, now I will show you other images. Look at this image. This image is the same image which I discussed with you. I have just added again. Here, what I have shown you is this is a right-sided kidney, which is puticini. This image, which is very commonly asked in the exam, that's why I have given to you. This is a left-sided kidney. I mean left kidney. The left kidney here has gone for puticini appearance. Okay, so This is the spine, friends. This is the entire spine. What spine? This is the lumbar spine, and this is the pelvic bone here. Okay, and this is the kidney part. So how you should be able to differentiate this? If you nicely observe, the entire kidney will appear calcified. Okay, as if it is like a cemented kidney. The entire renal calcification would be there. Okay, this is how you will identify putti kidney. Okay. Now I will take you to the next option. See here, this is the abdominal. What is this? This is the abdominal radiograph, that is abdominal X-ray. You are able to appreciate the spine. This is the pelvis bone, and you are able to see the head of the femur. Okay, and here is the our pathology. When you closely look at our pathology, you will be able to appreciate that not the entire kidney is involved, but it is filling the region of the pelvic Anion system. This is what you must observe here. So what has happened here is, the patient, as a normal physiological process, the patient is urinating. While urinating, what happens through the collecting ducts, tubules, it enters the pelvic Anion system. And there is a formation of calculi because of stagnant urine. Okay, so what happens? It is taking up the shape of a staghorn. What is staghorn? Staghorn means in European countries, the deers will have horns like that, which is called a staghorn. Okay, so it is taking an appearance of a staghorn. This is called staghorn calculi. Okay, so same what we have done a CT scan, friends. So what is this image? This image is an axial section CT scan image. Okay, without contrast. Okay, at the level of the kidney, which is showing a calculi, right? So this is very hyperdense, that is white in appearance, right? In the kidney, within the kidney, you are able to see a staghorn calculi. So this is a left staghorn calculi, and this is an example of right staghorn calculi. Okay, so what we have done right now, option A I have shown you, option D I have shown you. Now I will take you to another one image, an interesting image. Look, this is an abdominal X-ray, right? Here you are able to appreciate this is the lumbar spine, and this is the pelvis. This is the another pelvis side. Okay, here when you look closely, you are able to see a calcification present, which is appearing like this. Okay, but when you look at this image, friends, putti kidney, you are able to see ureter like this. Okay, on the same side, here is the spine. Okay, and this is appearing like this. So what I am coming to say to you here is, in case of putti kidney, spine was like this and the ureter were like this. Okay, remember this direction. In case of calcified psoas abscess, this is the spine, same side, you will be able to see calcification like this ones. You are able to appreciate the difference. It is coming in this direction, and this is coming in this direction. So this is a classical example of psoas abscess. What psoas abscess? Only when it is calcified, you will be able to appreciate in case of an X-ray. And this is a classical example of calcified psoas abscess. And another thing, what I have done is, I have collected important findings that is related to our putti kidney. So you will be able to appreciate a calcified kidney, which is called a cemented kidney or putti kidney. Okay, and how will be the ureter? The ureter will be showing you a sawtooth appearance, beaded appearance, or pipe stem ureter. Bladder calcification. Okay, now try to come up with a condition where you can see bladder calcification. That too calcification which is appearing like a fetal head, a fetus head. That is, as I discussed with you earlier, it is schistosomiasis. Okay. Now, I will show you another image. Here, friends, This is our fourth option. Remember, I will tell you a golden rule in medicine. That too in while doing a PG preparation. Remember, whenever you say a condition, systemic condition, a systemic inflammatory condition, a systemic anti-inflammatory condition, okay, you are able to find what to say. It is like a systemic condition, inflammatory condition, okay, rheumatology condition. Mostly the chances are it will appear bilateral. Remember it, bilateral. Whenever you are talking about trauma or infection, mostly it will be unilateral. Okay, because systemic condition, since it acts at the level, that level, it will be able to penetrate, it will show a bilateral penetrance. Okay, so here what you are going to appreciate is, this is a classic example of nephrocalcinosis. What is this? I am showing you, this is the right diaphragm, right hemidiaphragm, left hemidiaphragm. First of all, at your level, what is this modality that being used? This is a CT scan. Okay, what section? We are seeing a coronal section. Okay, and what is the window shown? The window is bone window. Okay, as I discussed with you earlier, this is the right lung, this is the left lung, this is the right diaphragm, this is the left hemidiaphragm, and this is the liver part, this is the spleen, and below the liver, this side you will be seeing the right kidney, and below the spleen, this side left kidney. This is the spine part, vertebral spine. Here you are able to appreciate the pelvis bone. In the coronal section, we have done all the other things. Okay, we are appreciating only calcification here, and it is a typical example of nephrocalcinosis. First of all, sir, how you are telling it is nephrocalcinosis is, remember, the entire kidney is showing calcification, but it is excluding the pelvic calyceal system. The pelvic calyceal system which will be appearing here is spared. Okay, ureters are spared, pelvic calyceal system spared, and urinary bladder is spared here. So with this, I'm coming to the diagnosis of nephrocalcinosis. Surely they will give you a background picture of hyperparathyroidism, milk alkali syndrome, medullary nephrocalcinosis, or a patient with sarcoidosis. These are all one way or another having hypercalcemic condition. Okay, so today I have covered a very important topic, friends. Okay, it is our renal system, genitourinary system, and radiology. So all the four options, okay, not only the four options, even other options which are related to these conditions, I have decoded for you. But these are all very important condition in their own self. So have a revision of this topic so that you will be able to know, not make mistakes, and you will be able to achieve it. Thank you, friends. With this, we are coming to our end of our discussion today.
I welcome all of you for a high yield series in surgery for upcoming INICET PG and NEET PG and next PG. The question reads, all of the following statements are correct regarding the shock reaction in burns patient except. Okay. Burns produces an inflammatory reaction, option A. Option B, this leads to a vastly increased vascular permeability, and water and solutes proteins move from the intra to extravascular space, and volume of fluid lost is indirectly proportional to area of bone. What is your answer? The right answer is option D. Why option D? Bailey and Love, 27th edition, page numbers 619, says what? In summary box 41.4, it very clearly says, shock reaction after burns. Number one, burns produces inflammatory reaction. This leads to vastly increased vascular permeability. Water and solution proteins move from intra to extravascular space. The volume of fluid loss is directly proportional. In the question it was given indirectly proportional to the area of burn. And above 15% of surface area, the loss of fluid produces shock. Correct? Now, the fluid of choice, questions will be asked is, fluid of choice in burns. Answer is Ringer lactate. They'll ask you, what is Parkland formula? How will you calculate volume of fluid for resuscitation? It is 4 ml per kg per percent burn area. So total volume calculated. So total volume calculated, 50% should be given within first 8 hours. Since burns, rest 50% should be given within 24 hours. Since burns, not from admission. Okay. Now they'll ask you cause of death in burns is sepsis. They ask you cause of death in early burns. The answer would be shock. Hypovolemic shock. Is it okay? Have you understood? So very clear. The question will be asked in burns. So similarly, you have interesting questions that are discussed by eminent faculties of Speed, and I wish you be part of Speed Learning app and Speed family. Welcome.